Good morning, everyone. Welcome to the webinar on polysomnography. Welcome to Indian Association of Respiratory Care. I know we have a very good response today. I'm Dr. Soumi Johnson, who is the General Secretary of Indian Association of Respiratory Care. Today's webinar is organized by a very special team from Maharashtra Regional Committee. We have a very enthusiastic team of respiratory therapists there. I have few announcements to make before we start. Since it is a Zoom platform, I request all the participants to keep your mic mute. Can I expect that from you now? Please see if your mic is open or mute. Please mute because the noises would be a disturbance to the talks. So kindly do that. Eventually, if we get a disturbance, we will be forced to remove that participant because we have around already 121 participants now. So if it would be a very much disturbance. So I request all the participants to mute your mic now. And there is a chat box here. So if you have any questions, please feel free to type your questions. And at the end, when the moderator tells you to ask questions, you are welcome to ask questions. Little bit about Indian Association of Respiratory Care. This is a 16, 17-year-old association formed to unite the respiratory therapists in India. We have very young group of respiratory therapists in India. We have education starting from diploma, bachelor's degree, master's degree, and doctorate and postdoctoral fellowship in respiratory therapy in various universities at government level and private sector in India. And we have a very high demand of respiratory therapists who are trained in India to work abroad in all the countries, especially the Middle East and also the Western countries. So Indian Association of Respiratory Care is where we unite respiratory therapists, and we have specialized services for the members. Now I see that many of the non-members also have joined were enthusiastic to join today's webinar. We are very happy to note that. So eventually, if you are a respiratory therapist or anything connected to the healthcare, we have options to make you members. We have associate membership for non-respiratory therapists. If you are a doctor or a physiotherapist or any other medical professional, if you are a respiratory therapist, if you are a student or a working professional, please log on to IARC website after the webinar, and the fees for the membership is very reasonable. You will see that. So this may be the last or maybe very few one which is free for non-members. So from the new year, we may have only for the members. So kindly log on to the IRC website and be members and take the benefit from that membership. So without much delay, I welcome the Maharashtra Regional Committee of Indian Association of Respiratory Care. Before that, I would like to say that we have, since it's a big nation and a very populated country, we have decided to make it regions and sub-regions. So we have different regions. We have Maharashtra, we have Bangalore, Karnataka, Kerala, we have Tamil Nadu. So we will have many more sub-regions and regions. So today's webinar is by Maharashtra region. So I welcome Ms. Rujita to take over. Thank you so much.
Thank you so much, ma'am, for that kind introduction and giving us an insight of the working of the Indian Association of Respiratory Care as a whole. So I would like to take it on from here. So first of all, a very good afternoon and a very warm welcome to all the delegates and the dignitaries and the students present here. I'm Ms. Rujita Bagri. On behalf of the Maharashtra Regional Committee, feel elated and extremely pleased to welcome you all, the distinguished speakers, my fellow respiratory therapists, and all the delegates on behalf of the organizing team of the webinar on polysomnography. It gives me immense pleasure and it makes me extremely joyous to have you all here. I mean, this is something that we had been planning, and it was into the planning since quite a while now. So I am elated and excited that we have finally put into this and it's happening. So first, I give you all, I extend a very hearty, warm welcome to all of you. And I would also like to appreciate the executive committee of the Indian Association of Respiratory Hair for their strenuous efforts, which have made this webinar possible. So thank you once again. Moving ahead with our webinar, the polysomnography webinar will comprehensively cover the 6 topics. First would be the polysomnography overview, which would be providing a comprehensive introduction to the field of polysomnography. Second talk would be on deciphering the sleep assessment, which would explore the effective methods for assessing the patient's sleep disorders and specific needs. A third talk would be on mastering the patient hookup, which would have an insight on detailing the essential steps and the techniques which are required for the meticulous preparations of patients or for the sleep studies. Then we move on to a session on basic sleep special procedures, which will have an in-depth exploration of the advanced topics, including the home sleep studies and the multiple sleep latency tests. A very interesting topic would be coming up soon after would be on the CPAP titration study, which will give us an in-depth knowledge of the CPAP treatment and which is being used extensively in managing patients with breathing-related sleep disorders such as sleep apnea or hypoventilation or hypoxemia. And the last session for the today would be addressing the art of conveying CPAP therapy to patients effectively. So before we move on to these sessions, we have a very exciting group of sessions coming up in the next 2-3 hours. So before we move on to that, I would like to request all the speakers to kindly keep into mind that to restrict their talks to 25 minutes, considering the interest of the time. The organizing team would give a 5-minute buzzer just as a reminder for you to conclude your session. I would also request all our delegates to cooperate with us for the smooth conduct of the session. So requesting all the delegates, as ma'am just mentioned, to kindly keep your your mics muted throughout the session so as to not cause any difficulty to the speakers. Unfortunately, we might have to move you to the waiting room in case if it is not done. Also requesting all the speakers to put in their questions in the chat box. We would take them after each session. And the last is and all the delegates are mandated to fill the feedback forms, which will be available at the end of the session in order to get your certificates. And also it is mandatory to attend the session. So complete attendance for the session and the filling of the feedback forms is essential to receive your certificates, participation certificates, which will be available in a month's time from the seminar. So we should move on with our next first session for the day. I am extremely elated.
I'm so sorry to interrupt. Just
Yes.
one reminder for everybody who's attending. Please change your names to your full names so that your attendance gets marked. We do not know who it is if you've written iPhone or if you've just written an abbreviation AVU or whatever. So please requesting you to change your names to your actual name so that your attendance gets marked for the certificate. Thank you.
Yes. Thank you so much, ma'am. I just missed out on that. So we should move on to the first session. It's my great privilege to have and welcome Rafiq sir, who is one amongst the renowned names in the field of sleep medicine and polysomnography. Sir has completed his Master of Respiratory Care from USA and has numerous fellowships to his name in the field of sleep technology. Sir is also has almost over 20 years of experience in the field of polysomnography and numerous publications to his name. So today, sir will be talking about taking us through the polysomnography overview. Over to you, sir. And thank you so much for being present to us today.
Hello. Can you hear me?
Yes, sir, we can.
Okay, so thank you for the kind introduction, and I would like to extend my sincere thanks to IARC and the Maharashtra Regional Committee for giving me for this opportunity to talk on my passionate area of sleep and polysomnography. Without further delay, let me go into the topic. My name is Rafiq Kandi. Currently, I'm working as a lead sleep technologist in Cleveland Clinics, Abu Dhabi. So I would like to ask everyone to use, if possible, they can use from the laptop so that we have some interesting sessions coming down. So what is the objective of this talk? So it is just basically to walk you through the field of polysomnography and what are the different types of the test conducted in the polysomnography. To give a general overview of the sleep and the sleep disorders commonly encountered in the sleep lab, and to offer an overview of the scoring and reporting process in the sleep studies. So before going further, if anyone is watching from the laptop using their mobile, please scan this QR code to take some few basic questions. Let me give you a few minutes for that. So please scan this QR code, so you'll be taken to a questionnaire. I think nobody joined yet. Can anybody join? Oh, all right. I can see. All right. Yes, please go ahead. Let me give you a few more minutes. It is nothing but it's a simple questionnaire, so nothing to worry about how much you know, you don't know. Nothing to worry about that. Just participate. Yeah. Few more seconds. Very good. So there are a lot of participation happening. So let's move to the first questions. Average sleep requirement for a middle-aged adult is, can you select A, B, C, or D? All right, I can see that half of them already answered. Please make it fast. All right. So the correct answer is, so most of the time, most of the people, 76% said it is 6 to 8 hours. As per the National Sleep Foundation, it is 7 to 9 hours. All right, so what is the next question, which is the most common sleep disorders in the general population? Few more seconds. All right. So it is almost 50-50, but majority answered insomnia, which is the correct answer. But sleep apnea, it depends on what type of research articles you are reading, based on where it has been done or not. But in general population, it is considered to be the insomnia is the most common sleep disorder. We'll be discussing further details down the road. Now, the third question, how much time an average adult spend dreaming on an average night? How much time do you think? Is it only a few seconds, 5 to 10 minutes, 1 to 2 hours, the whole night? Few more seconds. All right. So, all right. So it is interesting to see that 55% says that it's only 5 to 10 minutes, and some of them already said only a few seconds, which I cannot blame you guys. But the exact answer, the good answer is 1 to 2 hours you will be dreaming every night. We'll come back to that again. So to discuss what is polysomnia. Polysomnography is a recording of multiple parameters of the sleep, which includes the sleep parameters, respiratory parameters, limb movement parameters, and cardiac parameters. So all these 4 parameters is called as a polysomnography, a comprehensive polysomnography. You will be also having a video to see the abnormal movement, talking, shouting, screaming, and all those stuff. So this makes it the comprehensive technique. So these are the wires or the sensors which will be connected to the patient's body to get this full comprehensive analysis of the recording. So we have the EEG recordings, EOG recordings, chin EMGs, ECGs, and the respiratory effort, thoracic, abdominal efforts, and then flow cannulas or thermistors. Then we have a microphone, leg EMGs, body positions, and others. So the next speaker, Raid, will be discussing about how all these sensors will be connected in a systematic way. Once a patient comes to you, first what we do is to take an assessment and as patient preparation, which will be discussed by Dr. Saumi. And after that, we will start connecting all these wires and sensors. So in a polysomnography, what is happening is that we connect all the EEG, EOG wires in this parameter, in this format. And you can see that the flow and thermistor are also connected with the abdominal and respiratory effort. To see leg movement details, you will be connecting the EMG to the leg as well. And all these connected, and then what happens is that all these connected and everything will be getting connected to a head box, which is then connected to the screen or the computer to view the recording of the waves. Once everything is connected to the computer, and the end result will be something like this, what you see in the screen right now. So we have what we do in the sleep study is that we record and analyze all these parameters and data and play with it. So what we can see here is that in the first top parameter is the LOC, ROC, which is the I channels, and then below is the F3, F4, C3. All these are the EEG channels. So I said we have 4 parameters of interested recording. One is the sleep. So for the sleep, we need EEG, EOG, and EMG. So we can see that these are the EOG, and this is the EEG, and this is the chin EMG for the sleep recording. So these are the 3 parameters required for the sleep. Then when we move down to the respiratory side, we have thoracic and abdominal effort. And then we can see it's chest and abdomen here. And then we have the flow requirement. So this is a temperature-based flow or a pressure-based flow. There are 2 flow-based flow waves you can see here. And very importantly, you need to have the SpO2. And then additionally, you can have a snore and the body sensor. So we covered so the sleep parameters, and then now we have what we have seen what all things is required for the respiratory parameters. And then the next thing is the leg movement of the parameters, which is the right leg and left leg, anterior tibialis muscles. And then lastly, we have the cardiac parameters is the ECG. So these are the 4 parameters of recording, and then we have the video to see what is happening to the patient while recording. So the question is since we have seen there's a lot of EEGs and videos and cardiac monitoring, is it a part of the job of the mind? Of course it is. So when you look at the position statement from IARC, you can see that The responsibilities of the artist also include the diagnostic activities, include the performing of sleep disorder along with many other activities, and then therapy side, which includes the sleep support. Similar is the case with the CSRT, Canadian Society of Respiratory Therapists, and their position statement on respiratory therapists on primary care teams highlight that the sleep disorder screening and management is part of respiratory care. So, is it included in majority of the universities? It's getting started. The sleep is getting important in the curriculum. We can see this is from the Texas State University, where there is a specialized modules on the polysomnography alone, and you can be specialized. And from an Indian perspective, we can see that I was just reviewing the Rajiv Gandhi University prospects or the syllabus. And it is point for us, until 2018, there were no mention of the sleep, but after that, a review syllabus mentioned scattered importance of the sleep medicines, even though it is not an organized form. So there are some universities like our IARC Academy chairman, Dr. Manjush is heading a university here in UAE, where there is an entire module concentrating. So now the first question we ask is how many hours of sleep is required for an average adult? According to the National Sleep Foundation, you can see that 7 to 9 hours is the recommended sleep. Once again, the sleep requirement changes based on the age of the patient. And you can see here the 6 is the minimum lowest and the 10 to 11 hours is the maximum. So don't think sleep is like a medicine. It's like don't take it too much or you don't reduce it to than recommended. So there may be some exceptionals, like there are some long sleepers and short sleepers. Exceptions there always. So when we go down deep into the sleep, what is a sleep state or what are the sleep different stages? We know that we have NREM sleep and REM sleep. NREM sleeps mentions N1, N2, N3, and REM sleep, which is the dreaming sleep. So you remember the question, like how many minutes you think that you are dreaming. The REM sleep is considered to be the dreaming sleep. It corresponds to 20 to 25% of the total sleep time. Let's imagine you sleep 7 hours. What is the 25% of the 7 hours? It is something between 1.5 hours, right? So so why we need to know the details of this one? Why we deal with the sleep disorders? Basic understanding of this sleep architecture is important. So once again, the NREM sleep, which is the non-rapid eye movement, which is N1, N2, N3, makes about 75 to 80% of the total sleep time. And here you can see the N3, which is the deep sleep, which is, you can see in the hypnogram, the N3 sleep is happening in the first half of the night. And then what is marked in this black or the dark is the REM sleep. You can see REM sleep predominates mainly over the second half, and the N3 sleep predominates mainly in the first half of the night. All right, so which means that you will be dreaming much during the early morning hours, which is usually happening. Like whenever you wake up in the morning, you know that, oh, I was in a dream. You will dream almost 20 to 25% of the time, but you may remember only a few seconds of the dream. All right, so this is the basic. That was the basics of the sleep stages. When we go to the sleep studies based on the number of electrodes used, there are 4 types of sleep studies. First one is the type 1, or otherwise they call it as a level 1 study, which is the comprehensive full night polysomnography, where all those wires into the head, face, body, including EEG, EMG, everything is recorded, along with an attended sleep technologist or a sleep therapist with video. That is what is called as the type 1 fully comprehensive. Then what you have is the type 2. It is the same thing. What is the difference between is there is no one attending the patient and not viewing the patient, and there may be or may not be. So exactly the same thing, all the EG and there. Then third one is the type 3 or the level 3, where it is considered to be the part-time sleep study or a home sleep study, where you will not be attaching any of the EEG, EMG, EOG, which is required for the sleep recording, which is not there. Then what is remaining? The only respiratory side. So we will be connecting the thoracic and abdominal effort bells and the flow cannula along the SP props. And the last one is the type 4, which is, for example, you are doing only an overnight oximetry, which is considered to be the type. And then there is a peripheral arterial tonometry type, which also will be discussing. Yes, we'll be discussing in the next talk. So what is that means that if you have all of these 4, it will be type 1 along with a technician attending it. And if there is no this one and this one, only the flow and the thoracic and effort and abdominal belt along with the SpO2, it becomes an type 2. And if there is only the SpO2 probe or something like that, it becomes type 2. So why we do a sleep disorders, sleep studies to assess the sleep disorders? What are the common sleep disorders? According to the International Classification of Sleep Disorders, ICSD-3 from American Association of Sleep Medicine, there are 7 groups of sleep disorders. One is the insomnia, which we found that it is the most common sleep disorders in the general population. Then comes the sleep-related breathing disorders, the most common sleep disorders which we encounter in the sleep lab. Disorders. It includes sleep apnea, hypoventilation syndrome, like that. Then comes the sleep disorders of hypersomnolence. So sleep disorders of hypersomnolence means before I go to the sleep disorder of hypersomnolence, let me come to you what is the obstructive sleep apnea is all about. You can see here, this is how your normal airway. So when you breathe in, what happens is that air goes inside through the trachea, and then oxygen getting oxygenated, and then carbon dioxide get washed out, right? So what happens during sleep apnea is that, see the tongue which falls below and it occludes the airway. It can be partially obstruction, as you can see right now, it is a partially obstructed. So the flow of the air will not be sufficient. It may cause a snoring and awakening from the sleep. It is otherwise called as hypopnea. It may cause an arousal from the sleep, or it may cause a slight desaturations. And sometimes, it may completely block the airway so that the air will not go into the lungs. And the patient is trying to breathe, and after some time, the patient gasps and opens the airway. So because of there is no airflow, the oxygen goes down dramatically. It may go from 100 to 90s, varies from patient to patient, and sometimes you may see it's going up to 40s, 50s, 40s, 30s, like that. All right, so the first one is the insomnia we discussed, which is the most common. What is that? It is inability to initiate or to maintain a sleep. Both are considered to be insomnia. Then the sleep-related breathing disorders, we know there is sleep apnea, obstructive sleep apnea, central sleep apnea, obesity, hypoventilation, etc. And then comes the central disorders of hypersomnolence. Here, there is no breathing problem. There is no insomnia, but the patient is excessively sleepy during the daytime. So here it comes the narcolepsy type 1, narcolepsy 2, idiopathic hypersomnia, Klein-Levin syndromes, like that. So we will come back about that. Then comes the circadian rhythm sleep-wake disorders. Here you see like advanced delayed sleep phase syndromes, or those who are traveling far away. It's called as a jet lag, so difficulty to sleep getting. And then since we are being in the medical field, when we have to take night shift, day shift, night shifts, and because of this frequent shift, you will see shift worker disorders, inability to get good adequate sleep. So in this case, you don't have any breathing problem, you don't have any insomnia, you don't have any daytime hypersomnolence due to sunburn problem, but it is because of your rhythm disturbances in the circadian wake and sleep. Then there is something called as the parasomnia. Here there is an abnormal movement, fighting, shouting, screaming, things like that. You know that sleepwalking, sleep sleep-related eating disorders may go and eat food without knowing that he was sleeping. You may see like missing the food from the fridge. Sometimes you see sleepwalking, sleep terror. If you can sleepwalk, if you can sleep eat, if you can, then there could be sleep killing. So homicides that sleep sex is there, so like without knowing. So then in that case, it become a medical legal cases as well. Then there is something called as a sleep-related movement disorders. Here, what the patient is having leg movement, for example, restless leg syndrome. Here, what that happening is that the patient is having undue unpleasant sensation in the leg, so it is not helping them to sleep, and it affects the quality of their sleep. And you know what is bruxism, biting of the teeth. It also affects the continuation of the sleep. Then there are some other sleep disorders as well, which is includes seizure disorders and things like that, which we will be discussing further in details beyond the basics. So based on the type of the order or the request, we can divide the sleep studies into diagnostic polysomnogram, by which we diagnose as sleep disorders. We discussed the 7 sleep disorders. Insomnia. To diagnose insomnia, you don't need a sleep study because it is just like a clinic diagnosis. But to diagnose a sleep-related breathing disorders, you need a sleep study. To diagnose a central disorders of hypersomnolence, you need a sleep study. To diagnose a circadian rhythm sleep-wake disorders, you don't need a sleep study. Parasomnias also needs a sleep study. Sleep-related movement disorders, RLS, it is a clinic diagnosis. Bruxism is also clinic diagnosis. BLMD needs a sleep study. And if other disorders like nocturnal sleep, seizure disorders, you need a sleep. So you need to understand why we are doing a sleep study and what we are expecting out of ours. So diagnostic polysomnogram means what you are diagnosing as sleep disorders. Then if you diagnose a obstructive sleep apnea, let's say, or a hypoventilation, obesity hypoventilation like that, the patient need a treatment, and how we can do that. That is what is called as a PAP titration polysomnogram. And down the road, Sulochana will be enlightening us with the techniques how to get the PAP polysomnogram. What is split night polysomnogram? Split night is nothing but dividing a single night into a diagnostic portion and then a therapeutic portion. So here in the first 2 hours or 3 hours, the patient will be sleeping with all the senses, and we diagnose that he is having a breathing problem. And then the second half, we start connecting the sleep study, and then find out what ideal pressure is required to control his sleep apnea. And then there is a special procedures like MSLT and harm sleep testing, which will be covered in the beyond basics, the special procedures. So in short, the diagnostic polysomnogram, PAP titration polysomnogram, and the split night MSLT is happening inside the lab. Home sleep testing can happen in the home settings. So, so if you ask me, what are the scope of a work for a sleep specialized respiratory therapist? So they can work in sleep lab to conduct these sleep studies and monitor the patient's sleep pattern, collect the data, and diagnose sleep disorders. And then daytime scorer reviewing of the PSG recording. So we have seen that it's almost in, 6 to 7 hours the patient will be sleeping in the sleep lab, and then you have to assign each epoch of 30 seconds what stage it is. Is it an W or an N1, N2, N3, or run? So you have to until the last, that means almost 900 to 1000 epochs will be there. And then you have to come back and score the respiratory events and how many events are there. So scoring is a time-consuming procedure. It may take almost 1.5 hours for a single study alone. Then there is something called as a sleep navigator. So sleep navigator is the someone who is assisting the healthcare system and finding out what the sleep disorders are there, especially when inpatient sleep setting. So we'll come back to that in a minute. Then the sleep specialized artist can also work in the CPAP clinic to help with the sleep patients who is on CPAP therapy. So you teach the patient how to use the CPAP, what are the do's and don'ts, and how to get benefited out of this one. And the Satwa will be discussing about mainly on that topic. And then home sleep testing. So you will be teaching the patient how to use the home sleep studies, having an artifact sleep recording. And then you also, the sleep is relatively new area, and there is a lot of opportunities for the research as well. So you can see here the prevalence or the comorbidity of OSA in the associated disorders. You can see that OSA is present in 35% of the hypertension patients, and 49%, almost half of the atrial fibrillation patients do have OSA. Patients with diabetes, 72% of the diabetes patients do have OSA. Congestive heart failure, 76%. Of those with obesity, 77%. And if you take a drug-resistant hypertension, so the patient is on hypertension, multiple drugs is there, still it is uncontrolled. The chance for having sleep apnea is way high. And then nocturnal heart attacks. And if you add the respiratory disorders like COPD, obesity, the chance for the OSA in those populations is very high. Which means that when the patient comes to the hospital and get admitted, and there is a multiple admission because of any of these problems, the sleep navigator go and find out whether this patient is a candidate of a sleep apnea. How we do that? It is by doing a screening and a questionnaire, which will be discussed by Dr. Saumi in a while, and how to find out these patients are a potential candidate of a sleep apnea or not. So the sleep navigator, the job is to find out, identify the comorbid population for the sleep apnea, and to give a proper treatment for that, thereby reducing the readmissions and reducing cost reduction, and to give them patient educations and care coordination. And also, these are the sleep expert who makes the patient public and physician. So far what we discussed, what is the polysomnography, what are the sleep disorders, and how it is connected, and what are the different types of the sleep studies, and what are the job domain of the sleep specialized. So what the job of scoring means? The scoring includes the sleep staging, respiratory events marking, cardiac events marking, and leg event marking, because that's the 4 parameters of polysomnography, right? So sleep, respiratory, cardiac, and leg movement. So each and every of this one will be marked by the sleep expert. So you can see here, this is the marking is the 32nd, 36th epoch. So what that means is that, right? So this is a 30-second window. So scoring means as a sleep tech or a respiratory therapist who is dealing with the sleep, you score what stage it is, and then move to the next epoch of 30 seconds, and then next epoch of 30 seconds. You can see in this one, it is almost 1,000, more than 1,000 epoch is there. So you have to assign each epoch a stage. It has to be W, N1, N2, N3, or stage from. So you do that from epoch 1 to the last epoch. Then you come back and start scoring the respiratory events from this window. Then you continue till the last epoch and then come back again, and you just go through the ECG to find out any cardiac problems are there. And then lastly, you score the leg movement. So just to give you a brief idea of what is happening in the sleep scoring, so you can see in the top, so if there is any slide you want to take home, this is the slide you want to take home. When you connect all these wires, the head, face, and body, you record the EOG, EOG, and EMG. These are the three parameters required for the sleep scoring, and mainly the EEG. Here we can see that those already in the sleep field, you know, this is the alpha wave. If the alpha wave predominates in this epoch, majority of this epoch is alpha wave, it will be called as a wake stage. Or as you see, background EEG in this one is the theta wave. As you see here, that will be called as N1. And if during that time, when you are out asleep, and if there is a special characters like sleep spindle or a K complex is present, then you will call it as from there onwards N2 sleep. We know that wake means you are you are oriented outside, okay, you are conscious, and N1 is the light sleep. Light sleeps corresponds almost to 4 to 5% of the total sleep time. And then N2 comes, that is the actual sleep. I need you to wake, or make a sound to wake you up from the sleep. It corresponds almost to 50% of the total sleep time, which means that if you're sleeping almost 7 hours, almost greater than 3 hours, you will be N2 sleep. Then comes the delta, or the slow wave sleep. The frequency of your EEG waves become wide and tall. So when you see majority of the epoch like this, you call it as a 3 sleep. So you can see here, because of this is something called as the K complex. The presence of this K complex made this epoch to be scored as N2. So you will move to the next epoch and you score what that epoch is. This is what is the sleep scoring means. Then when you are going to the respiratory scoring, you will go to score the respiratory events here. So you can see that this is the normal breathing of the patients. This is the temperature flow and pressure cannula flow. There are two flow sensors used in the nose. And then we have a thoracic and abdominal level. You can see in this area, there is a normal flow of air. So inhalation, exhalation, along with the thoracic and abdominal effort. But when you look here, you can see that the flow is reduced and there is a desaturation from 97, 92. If you recall, before I showed you a video, what is happening is that is what is called as a partial obstruction, or otherwise called as hypopnea. If you go down to another slide, you can see here there is a continuous airflow, but see it is completely blocked, but you are trying to breathe. So this is otherwise called as an obstructive sleep apnea, obstructive apnea. Obstructive apnea is an event, and obstructive sleep apnea is a diagnosis. So it has to be, you should have that differentiation. So what, as a sleep expert, what you're doing is that you are marking all these events. You can see here there is an obstructive apnea, and here you can see there's a mixed apnea, and this is again obstructive. What is mixed apnea is that here there is no effort at the beginning. So that means it is a central component of the apnea, and then the resumption of the effort. It's called a mixed apnea. So you do how many events are there in the entire study duration, and you calculate. So you can see here um, um, in this one, you can see that, this is a recording here. You see there is a flow here, and then patients there is a cardiac, you can see a cardiac abnormality here as well as pulse. And from an EEG point of view, there is an arousal here, and the patient is not breathing, and then he start all of a sudden open up the airway and start breathing. This is what is happening in obstructive sleep apnea, and it continues. After some time, it continues again the same thing. There is no breathing, and there is an arousal. This continues how many times? How many events are there for this patient? This is what is all about respiratory scoring. So once you sleep stage, so you know how many, what's the total sleep time of the patient. Then you come back to the respiratory side and you mark each and every event, and then you divide it with the total sleep. If the respiratory events, if you have apnea, how many apneas are there? How many hypopneas are there? It is indexed per hour, and it is called AHI. It is the marker of a sleep severity. A normal AHI is something less than 5, and a mild obstructive sleep apnea is considered when the AHI is between 5 to 14, and moderate is something between 15 to 29. Anything above 30 is called a severe. So now we know what is the severity classification just based on the polysomnography. But a classification not only depends on the OSA, it depends on the patient's symptoms as well. What are the symptoms of the OSA? Patients will be having excessively sleepy during the daytime, snoring, nocturia, then not no energy for anything, tiredness, fatigue, and what the common signs are there like shock knock, retrography, crowded airway, lymphatic 3 and 4. So based on the patient presentation, based on the patient clinical presentation, based on the patient's sleep study presentation, so you will be classifying the severity. So we scored sleep, we scored respiratory. Now we will move into the leg movement, which is we have seen that the PLM of the sleep. So now you can see here, right leg and left leg is having movement. So the patient will be moving the legs like in a periodic movement, periodic fashion, usually 20 to 40 seconds. So when the legs move, the patient get aroused, and sleep will not be a continuous process, and then next day the patient will be sleepy. So you mark each and every leg movement, and then similar to the AHI, we will be having something called as leg movement index as well. So just to give you a rough idea of neurobiology of the sleep. So here you can see that from VLPO is considered to be the sleep switch. So what happens is that during the darkness, during the night time, so the retinohypothalamic tells you that there is no light outside. So pineal glands secrete a hormone called melatonin. Melatonin, and due to the presence of the adenosine as a backup of the ATP. So what happens? It stimulates the VLPO and say, "Yalla, go to sleep." So from then onwards, the sleep starts. What happens is that it inhibits the all the other wake areas like basal forebrain, dorsal raphe nuclei, or the PPT, pedunculopontine tegment, and whatever. So these things produces the neurochemicals which is required for the to keep you awake. For example, TMN produces the histamine. Histamine. You know what you will feel if you take antihistamine. If you take antihistamine, you are sleepy, right? You will be drowsy, which means that what is the function of the histamine? Histamine make you awake. Similarly, the dopamine, what happens if you have a dopamine surge in your body? When you are with a loved one, your crush or whatever, will you feel sleepy? No. When there is a rush of dopamine in your system, you will be awake. So these are the hormones or neurochemicals like acetylcholine, norepinephrine, dopamine, serotonin, histamines, etc. are the neurochemicals which makes you awake. And once the VLPO is active and inhibit all those neurochemical areas, you stop producing all these things, you you start sleeping. All right. What happens is that if there is a stroke, for example, most common sleep problem which happens with the stroke is obstructive sleep apnea because of the muscle weakness, a lot of other factors. But if you have a stroke pertaining to the VLPO, which means that VLPO will not function and you have insomnia. Oh, and this the same is the case with the other wake promoting areas. I know this is a little bit complicated area, but the point I am trying to tell you is to be a good sleep guy or expert, you need to have a better understanding of anatomy and physiology of the neuroanatomy and respiratory anatomy and how the things are working. This is an example. So, and as a respiratory therapist, we know that there is something called as hypoxic vasoconstrictions and decreased peripheral vascular resistance, how it helps, how it causes systemic hypertension. We have seen before that OSA is more common in hypertension patient and or those drug-resistant hypertension patient. Why? You will be able to explain to the patient the frequent hypoxic vasoconstriction happening along with the apnea and hypopnea is the cause. And similar is the case with why you have nocturnal enuresis, going to the bathroom several times, or why you have atrial fibrillation, as I call comorbidity along with OSA. So you need to have a good understanding of anatomy and physiology of the respiratory system. So in short, as a to be a good sleep guy or a good expert on the sleep, you need to have a better understanding of anatomy and physiology, sleep disorders, and patient assessment skills, and then sensor application, patient hookup. So it will be discussed soon, and then data monitoring and management, sleep staging, event scoring, the PAP titration, which will be discussed by Sulochana. Then artifact recognition, you should find out whether it is an fact or an artifact, whether it's a signal, a good signal or a bad signal. And then interpretation and reporting, and to find out the cardiac abnormalities associated with it. We have seen some patients who have doing hospital shopping from hospital to hospital, finding out what is the problem. And when we do the sleep study, there is no respiratory problem, there is no central disorders, hypersomnolence, nothing but ECG abnormalities, and then we have taken them to pacing immediately. And then PAP teaching, CPAP data downloads. So the big question here it is, are you guys ready for the to be in the part of this fantastic sleep part? So in short, the conclusion, what all things I discussed is what is polysomnography, what are the different types of sleep studies, what are the different sleep disorders, and what is the role of sleep scoring, sleep scoring, reporting, job domains. So if you are ready, now we have a post assessment as well. If you can scan the QR code, you will be directed to again for another question. Are you ready? If you're awake, please scan. Nobody. Okay, so let's start. Okay, you want some more time for this one to scan? Let's give some time. All right, so I can see few have already started this scanning. And what is the gold standard for test for diagnosing sleep disorders? Few more seconds. Almost 50% answered. The last Peter. So the answer, as majority answered, it's the 94. 6% answered it is a multiple sleep latency test. I cannot blame you because the question was not specific. I know if the question is about narcolepsy, you would say MSLT as well. But majority from a general population or general question point of view, polysomnography is the gold standard. What is the role of a respiratory therapist in polysomnography? If you're a sleep specialized respiratory therapist, what are things you will do? I am sure that most of you, or 100%, will be answering it correctly if you were listening to the talk. All right. Few more seconds. Almost. Okay. So, yeah, so monitoring and patient during the sleep study is a part of the job. Scoring and interpreting is a part of the job. Setting and calibration is also part of the job. Electrode application is also a part of the job. So it's all of the above is the correct answer. So sleep apnea is characterized by the pause or apneic spells in breathing while you sleep. In adults, how many pause or events per hour are considered normal? Normal. Sorry, I just extended few minutes additional, and I'm sorry, I apologize for that. But to convey the message, to give an overview of everything, I had to take that time. Sorry for that. All right, a few more seconds. All right, so up to 5 times per hour is considered to be the normal. Something from 5 to 15 is considered to be mild. Whether you want to treat it or not, that's based on the patient's clinical presentation as well. If you have daytime excessive daytime sleepiness and associated findings like nocturia, blood pressure, diabetes, and cardiac abnormalities, and things like that, even with an AHI of 5, you will treat. What type of treatment? That's a different question, but you need to be treated. All right. So next, the last question I believe would be which stage of sleep is characterized by rapid eye movement, sleep associated with vivid dreaming. This is the last question I believe, and I'll give you a few more seconds. If you were listening to the talk, I assume you would be answering this also. All right. All right, so a few, I think vivid dreaming doesn't happen in any of the other sleep. It's during the REM sleep. I think few were dreaming already while I'm talking, and hence they got a little bit all the answers. The last one, what are the potential role of a sleep specialist respiratory therapist? Collection of sleep data scoring only in CPAP clinic, sleep navigator only, and you know that all of the above is the correct answer. And the last one, of the following, what is the best documented risk factor for, say, cigarette smoking, obesity, alcohol consumption, and or the postmenopausal status. We know that obesity is the most common cause associated with it. Which type of a sleep disorder is frequently observed in stroke patients? Obstructive sleep apnea, change of respiration, insomnia, narcolepsy. We haven't discussed anything about the change of respiration, but that's seen in the stroke patients, but most common of is obstructive sleep apnea. Yeah, change. So I can see that change of respiration is being answered. It is change of respiration is seen in obstructive sleep in stroke patients, but generally speaking, most common sleep disorder in stroke patients is RSA. But it could be based on the presence of the stroke, where in the brain it is affects, as you saw in other slide, it may even cause stroke. All right. So congratulations, Balaji and Manchula, Selva, Kokila, who did very good answers on this one. And thank you if you have any questions.
Thank you very much, sir, for that lucid explanation. I think definitely it has been very helpful to all the delegates out here, and I can clearly see with the interest that they have put in into answering questions, and we have had quite a few participants answering in the chat box as well. So I think we have had an active participation on the session. So thank you very much, sir. Again, thank you so much.
Once again, I apologize for taking an extra time. Thank you very much, Maharashtra Regional Committee and IARC for this opportunity.
Thank you so much, sir. Thank you. So before we move ahead into the webinar, I have a kind request for all the delegates to kindly rename your names. I can still see a lot of delegates have been joining with the names such as iPhone or some other names, or with the names of their mobiles. So I think in that case, we would not be able to track your attendance, and you may not be able to receive the participation certificates. So please, I request, once again, would like to request all of you to kindly rename your names before we continue with the webinar. Moving ahead, we have the second session on deciphering sleep assessment. For that, we have with us today Dr. Somi Johnson. Somi Johnson, ma'am, holds a bachelor's and a master's degree in respiratory therapy from the Manipal Academy of Higher Education. She is also one of the PhD. She holds a PhD degree in respiratory therapy. Currently, ma'am works as an associate professor with the Department of Respiratory Therapy and Anesthesiology and Critical Care at Amritam Institute of Medical Sciences, Kochi. Ma'am is also the General Secretary of the Indian Association of Respiratory Care presently. It is a great honor to have you with us today, ma'am. Thank you so much, and over to you.
At the outset, I thank, 1 second. Yeah, I thank the Maharashtra Region Committee and all my friends for this opportunity. And it is quite difficult to talk after Mr. Rafiq because he has an enormous experience in the field of respiratory care, and I think he has covered a lot of information. So yeah, so apologize me if I am talking something as repeated information. I would try not to repeat anything that is talked already. So I would try to limit my talk as well. Let me share my screen. Is my screen visible?
Yes, ma'am, we can see.
Yeah, so am I audible now?
Yes, ma'am, you are.
Yeah.
Because all these floating meeting controls are in front of me. So
Ma'am, you just muted. Ma'am, you're muted.
yeah, I'm being muted
Yeah.
again. Yeah.
We can
Yeah,
hear
I
you
think
now.
I cannot do that. Yeah. So welcome to the topic on deciphering the sleep assessment. So I would be just talking about how do we assess the patient before we do the sleep study. I think that's my talk. So this comes from our school days stories on Pickwickian papers, where a character called Joe is constantly hungry, very red in the face, and is always falling asleep in the middle of task. And they say, the character says, "Sleep," said the old gentleman. He's always asleep, goes on errands of fast asleep, and snores as he waits at table. So even before it was defined, it used to be in our fictions. Um, Now, what is the prevalence of sleep apnea? We saw some of the information from the previous speaker. The burden of the problem is so much that that we need to screen these patients and all that. So the global prevalence in adult population that is around 9 to 38% of adults worldwide may have some degree of OSA, and moderate to severe OSA may be prevalent in patients around 4% to 20%. It varies in different journals, but 4 to 20%, that's how I got a general idea. Some say 6 to 17% and all that. So it's a big burden. And what is the prevalence by age and gender? In children, it does not just affect the adults, but also affects the children. Sleep apnea can also affect the children, especially those with enlarged tonsils or adenoids. We know that. And the prevalence in this group varies. A group is around 1% to 5%. And in adults, the prevalence of sleep apnea tends to increase with age, and we see that in the clinical setup as well. Among the middle-aged adults, it is more common, affecting approximately 9 to 24%. That itself is a very high prevalence. Now, in the elderly, what happens to the older population? The elderly population, 65 years and above, the prevalence may be higher, with estimates ranging from 20 to 60%. That is also very high prevalence. Now, is there any gender differences? Is it like more in men, less in women, or is it equal? The studies have found that sleep apnea is more commonly diagnosed in men than in women. But however, the gap narrows in older age groups. So as people becomes elderly, the gap becomes almost lesser. But now recent studies say that even in women, the screening is very less. So it is underreported, and that's why the reports are coming that men have more prevalence. Now, what about obesity and body weight? We just heard about this information from the previous speaker. Now, obesity, we all know that is a significant risk factor for many comorbidities, also for sleep apnea. Now, the prevalence is higher in individuals with higher BMI, and also the waist circumference matters. So it is associated with an elevated risk of sleep apnea. Now, what are the other factors? So genetic factors also play the role. There are evidences that the genetic components in the risk of developing sleep apnea, with a family history of the disorder increasing the likelihood. So there is a genetic predisposition. Now, what about ethnicity? Is there any role when people are from different ethnic group? Now, studies have shown that prevalence can vary by ethnicity, and the highest prevalence is seen in African Americans, Native Americans, and Hispanics. And African Americans are seen to have very high prevalence of sleep apnea when you talk about the ethnicity. Now coming to the assessment per se, the clinical history and interview is a must. It's not that the patient comes to the clinic and then you start doing the sleep study without taking the history. So this patient is like any other patient coming to the hospital with any other problem like diabetes, fever, pneumonia. So sleep apnea is also such a disorder. So we have to have a thorough medical history and examination of these patients. Now, other than the usual clinical history that we take in the medical history taking procedure and the physical assessments, we also can gather the information about the patient's sleep patterns, bedtime routines, sleep environment, any previous sleep related issues. So we have to take the details of these. Of course, we have to take the medical history to see the patient's overall health, medical conditions, medications that the patient is taking, lifestyle factors that may impact sleep. Now, whom are we talking about? Are we talking about the medical fraternity, the doctor, the pulmonologist? No, I am talking about the sleep tech or the respiratory therapist turned sleep tech who is going to do the sleep study for the patient. So we have to take the sleep history, clinical history, anyway, short clinical history and interview and the sleep history before we start doing the sleep study. And now we can have a set of questions like what time did you go to the bed? What time did you try to go to sleep early in earlier days? So we can have a set of questions. Now we can also have an assessment from the sleep diaries. Now it is not that easy when it comes to the behavior of a person. Now sleep problem other than the obstructive sleep apnea and the mixed sleep apnea and all that, it comes under the behavioral problem and psychiatric illness. Like so it has something to do with the behavior as well. So it is a little difficult if you go through the channel of the regular medical history taking and assessment. That's why we have to have few other things to take the clinical history and assessment. So sleep diary is a very good tool. Now, so the sleep diary explains the purpose. The purpose of the sleep diary is to understand the sleep pattern of the patient and the consistency and accuracy of the information that the patient is telling us. So patient has to really write the information in the sleep diary, and then you have to actually inspect the sleep diary when the patient comes to you the second time. Now, what can be the components of sleep diary? Bedtime, when the patient is going to the bed, and wake time, when the patient is waking up in the morning, sleep onset. So patient usually tells you the not the accurate time, maybe the approximate time. We need to have an accurate information. That is why the patient is asked to write things in the sleep diary. Sleep onset, number of awakenings in the night, time of awakenings, final wake time. People tend to get up, see their phones, see everything else, talk to people, and then finally get up from the bed. So this is the final wake time. Total sleep time, the calculated total sleep duration of sleep. Sleep quality, ask the patient to rate the quality of the sleep on a scale of 1 to 10, and then you can see very easily numerical scale. Nap information, record any daytime naps including their duration and timing. We had a patient who used to say that I can't sleep in the night. So when I took the history, he said, after I come from the work, I'm too tired. I sleep from 5 p.m. to 11 p.m. in the night. So I get up, have my food, then I don't sleep in the night at all. So the next day when he goes to the work, he had been warned because he is too much asleep. So if people take naps in between, then it can affect the sleep in the night. Now, daily activities also is important to note the type of exercises, duration, and the time of the day for any physical activity. So if they are doing the exercise just before the sleep, then it can affect the nighttime sleep. Caffeine and alcohol consumption, record the timing and amount of caffeine or alcohol intake. Meals. So caffeine and alcohol just before the bedtime can affect the sleep quality. Meals, not the timing of the meals, especially evening meals, when are they taking it? stressful events, ask the patient to document any significant stressors during their day. So why are we doing this is because is the problem related to, the psychological aspect of the sleep or the pathological aspect of the sleep. We have to differentiate it. So if the patient is really stressed, he has to get a cognitive behavioral therapy, and then we have to start doing our, the regular sleep study. So medication use, record any medication taken, including sleep aids. There are some medications which are diuretics also. So in between, they have to get up to go to use the washroom. So their sleep would be interrupted. So we have to make sure that talk to the doctor and then discuss about titrating that. Now, bedtime routines, ask about pre-sleep activities such as reading, watching TV, or using electronic devices. Some of them use all this in the bedroom itself, so that can distract them, and then going to the bedtime can be too late. Encourage, these are small things, tiny things, but it can actually affect the sleep quality. Encourage patients to document any relaxation techniques or rituals before bedtime that they usually do. Now, talking about the sleep environment, inquire about the sleep environment. How is their bedroom? Is it like full of electronic gadgets, and it is not very cozy to sleep, so they don't feel like sleeping in the bed. So the sleep environment has to be very comfortable to make sure that we get a very quality sleep. Room temperature has to be maintained. The noise level. So people who are living near the railway station and railway tracks, it will be very difficult for them to sleep initially, but they get adapted later. Or you have some party going on in the other apartment, and then you want to sleep, it would be very difficult. All these things are also important. Now, comfort of the mattress and the pillows are also important. Now, how do we analyze the sleep diaries? Review the patterns of the sleep, rectify the triggers. What are the triggers for them that does not allow them to sleep? Assess sleep efficiency, determine the trends, what is happening most of the days, discuss findings with the patients so that they take the ownership and then try to change. So behavioral changes only happen if the patient is educated well. It is very easy to put on a CPAP, but compliance of the CPAP again is again from the behavior. So that is very important. Using sleep diaries in the treatment is like developing sleep hygiene strategies. So we were talking about a lot of information which can be connected to the sleep hygiene. So first we have to give the sleep hygiene information to the patient with cognitive behavioral therapy. So the sleep diary is a very important tool for implementing this sleep hygiene strategy. Then behavioral interventions includes a cognitive behavioral therapy. So in a comprehensive sleep clinic, we would have a sleep psychologist or a clinical psychologist who can help us. And it also helps us to monitor the progress of the individual. So that's about the initial history taking, interview, sleep diary and all that. Now we would talk about the actigraphy. Now these are devices that can be worn to the wrist, and then it can record the movement and light exposures. So this gives you an objective data about the sleep-wake patterns and circadian rhythms over an extended period. So if you want to see the trends of the sleep patterns, or the problems of sleep-wake patterns of an individual, we can use it. So it uses an accelerometer technology to detect the movement. So it can also record the acceleration caused by bodily movement and distinguish between periods of rest and activity. That's how we get the information. Now coming to the gold standard polysomnography, our previous speaker already dealt with different I think he already told you about various nuances of the PSG, the waveforms, K complexes and all that. So we have to have a full-fledged polysomnography, level 1, level 2, level 3, all that are there. So polysomnography is a comprehensive sleep study conducted in a sleep clinic. It monitors brain activity through the EEG, EOG, will monitor the eye movement, heart rate, and ECG waveforms from the ECG. Of course, respiratory efforts, airflow, leg movement, saturation, all this will be recorded. Now, it is the gold standard to diagnose sleep disorders and also the REM sleep behavioral disorders. And if you look at this, hypnogram, I think the next speaker is going to dealt with the details of the scoring. So I will not go into that now. Just to tell you the snapshot of, what is happening during the sleep study. So this is a hypnogram. You get a accumulated data at the end, and then you get the oxygen saturation, desaturation. So you can see that a lot of dip is there. This is the 8-hour study hypnogram. You get all the graph together in that screen. So you can see that there is a dip here, and then again the saturation is going up, and then heart rate acceleration is also there. See, at many times the heart rate is going up, so heart rate acceleration, deceleration is there. Then there are incidents of obstructive sleep apneas here many times, and hypopneas are also there. Then sleep fragmentation, and there are sleep stage changes from different stages like REM, N1, N2, all that, everything is changing. And then there are sleep fragmentation as arousals. Patient is getting aroused in between. And then positional changes are also there. You can see the change here, right? In the graph, at least you can see that. And there would be, in the next talk, you will know in detail about this. So that's why I'm just telling you in summary. You can also see a lot of snoring here, right? So this is a hypnogram that you see usually at the first, when a patient comes to you and then you finish the recording. You will see this, and then you will see like, each and everything in detail. Now, these are examples of, some of the sleep studies that are done. So you can see the sleep efficiency, sleep latency, everything you can see. You can see how much time each, stages were there for the patient: wake, R, REM, N1, N2, N3. And you also see the obstructive sleep apnea, central sleep apnea, hypopneas, hypopnea index, RARAS, RDI, all that you can see. And in each of the stages of the sleep, what are the severity of each of these, apnea, hypopnea, and all that. Then you can also see saturation, minimal saturation, average saturation, snore index, all that you can see. Yeah, so just wanted to show you some of the, that graphs you will see. I'm not going to spend much time here because the next talk is on scoring. Now, yeah, there are apneas, obstructive sleep apneas. Yeah, so you see all that here in the waveform. You also see the saturations dipping up, dipping down, going up and on. Now that's about PSG. Now talking about home sleep apnea testing. Now, polysomnography has to be ideally done inside the sleep clinic. Okay. Now, what is home sleep apnea testing? We are taking a very small machine to the home, and then we do the sleep study. That is home sleep apnea testing. So whom do we do this? When the patient have moderate to severe sleep apnea, then it can be advised. But at many countries, you have to look at the legality, because sometimes if the patient requires or a CPAP, it has to be under the insurance. So I think we have to do a full-fledged PSG at the clinic for the insurance coverage. But however, home sleep apnea testing is existing. It can be connected to monitor the respiratory parameters in the home setting. And it is very convenient because the patient is sleeping in their own home. So they will not have a problem like of a new setup when they come to the clinic and all that. So it's very convenient for the patient. But there are also disadvantages. Now, that is about the home sleep testing. Now, talking about the screening devices, like now when you have a lot of patients coming to the OPD, and then you want to just see if they are at high risk of sleep apnea or somnolence and all that. So we have many questionnaires. Epworth sleepiness scale is very common, very popular. All of you must be knowing about it, I'm sure. ESS, it's a self-reported questionnaire that assesses the daytime sleepiness. So we do Epworth sleepiness scale to see whether the patient has a abnormal daytime sleepiness. Okay, it helps to gauge the level of sleepiness and its impact on the daily activities. I have just kept some of the parameters that we assess: sitting and reading, do you doze, watching TV, yeah, sitting inactive in the public place, yes, maybe. I do not know how many of you are sleeping in my talk, so it can happen. If it is a very boring talk, people tend to sleep, right? So we think that it is very much normal, but they say we have to think about it. People should be awake, even if it is boring, maybe. I hope nobody is sleeping now. I can't see, so I presume that you are not sleeping. As a passenger in the car for an hour without a break, are they sleeping, lying down in the rest to the rest in the afternoon when circumstances permit? So I do not know how many of we say no to it. So anyway, that's there in the question. Sitting and talking to someone, less likely people will doze off, but that's also there. Sitting quietly after lunch without alcohol in a car while stopped for a few minutes in the traffic, so that is too dangerous. So just to see how much likelihood is there for the daytime sleepiness. Now, if it is 0 to 7, if the score is 0 to 7, we say the person does not have abnormal sleeping during the daytime. And if it is 8 to 9, there is an average amount of daytime sleepiness. And if it is 10 to 15, then there is excessive sleepiness depending upon the situation. As I said, if the talk is very much boring, people sleep. That is 10 to 15. And 16 to 24, excessive sleepiness, whatever is the situation. Even if it is a very active scenario, very interesting talk, people sleep. So in these situations, 10 to 15, 16 to 24, immediate medical attention has to be sought. Now, talking about the next question, that is PSQI, that is also a very popular one. Pittsburgh Sleep Quality Index. This was developed by the professors at Pittsburgh University of Pittsburgh. That's why it's called Pittsburgh Sleep Quality Index. They are very kind enough to share the questionnaire in different languages to researchers. I have done a research with this in different ethnicity and all that. So they have shared that. So it's a very old one, 1989. It was initially published and all that. So it's a self-report questionnaire that assesses overall sleep quality and disturbance over a 1 month period. So if you want to know what's happening to this person for quite some time, so in the past 1 month, then you can use PSQI. So we have 19 questions there about the person, and 5 additional question that can be answered by someone who is sharing the bed with usually the bed partner. They can also answer about that. So this is a glimpse of the initial questions. It's a 19 question. There are 19 questions in this, so it's easily answered. It's a self-administered questionnaire. Now, from that, if the score is more than 5, we say the patient has, excessive sleep, high risk. So less sleep quality, we say. So this is to assess the sleep quality. So if there is a score more than 5, then we say there is a decreased sleep quality. So we usually give the sleep hygiene first with the cognitive behavioral therapy. Now, Berlin questionnaire is another one, which is very common in the clinical practice. It is useful for identifying the individuals at risk for sleep apnea by assessing snoring, daytime sleepiness, and hypertension. And now, in the Berlin definition, we see as 2 categories: high risk, if we have a score of, if they have answered yes to 2 or more questions, and low risk is 1 or no category. So that's how we come to know whether the patient is at high risk for obstructive sleep apnea, and then we can do the polysomnography for them. So this is, it's written here. So BMI, snoring, all that is important. Now, another questionnaire is stop bang questionnaire. Stop bang questionnaire was initially used by the anesthetist or the surgeons to actually evaluate in pre-operatively, but the validation are there for other populations as well, in CABG patients and all that, pre-operative, post-operative. So stop bang comes from snoring, tiredness, observed apneas, high blood pressure, BMI, age, neck circumference, and gender. That's how the stop bang comes in the questionnaire. Now again, this will tell you about the low risk and intermediate risk and high risk. If the answer is yes to 0 to 2 questions, it is low risk, obviously. Intermediate risk is yes to 3 to 4 questions. And then high risk is yes to 5 to 6 questions. So we have to, know before the surgery whether this patient has a sleep apnea or not, because post-operative events can depend upon the comorbidity. So it has to be assessed and then treated and diagnosed accordingly. So these are some of the questions of stop bang questionnaire. Now, we also have many other tests. I think we have another talk on MSLT and MWT today. So these are other, diagnostic tests, what comes under the test of the polysomnography. So multiple sleep latency test, maintenance of wakefulness test. We also have to see the nutrition and lifestyle assessment of the patient. We have to do the assessment of the lifestyle and nutrition. Mood and mental health also has to be assessed. As I said, sleep disorders, many of the sleep disorders are also psychological or psychiatric. So we have to differentiate between obstructive sleep apnea or pathological sleep apnea or the psychological. And I think I'm on time. Thank you for your patient listening. And if you have any questions, I can take according to whatever the moderators say.
Thank you so much, ma'am, for that wonderful talk. I think if we have any questions, we can put them in the chat box and then ma'am can take it up. Okay, we can then move ahead to the next session. Thank you so much, ma'am, for that talk. I think it was really a very great, and we got a lot of insights into that. We're moving on. We have the next session on mastering patient hookup by Mr. Mohammed Red. Yes. Mr. Mohammed Red holds a BSc degree in respiratory care technology from RGHS Karnataka, and he also has a registered polysomnographic technologist. Currently, he is working as a sleep respiratory therapist at King's College of Hospital, London, Dubai. So we welcome you, sir, and would request you to kindly take over the session.
Thank you. Myself, Udrait, I'm currently working in King's College. And we heard in the last two topics from Rafiq sir and Sophie ma'am, detailing about the overview of sleep study and patient assessment. So we can start, right?
Yes, we can, yes.
Now my topic is about how to connect the sleep study sensors and electrodes in the accurate way. So the objective of my talk is 1020 standard electrode placement for overnight polysomnography and discussion about sleep sensors and its placement. So we have heard from Rafiq sir in previous session, polysomnography is a poly plus somno plus graphy. That means it records multiple parameters during the sleep, like graphical representation of sleep, and it record multiple parameters. To record these multiple parameters, we need this electrodes. So 9 to 10 EEG electrodes and SpO2 probe and EMG electrodes, position sensor, and pressure transducer, and EEG electrodes, snore microphone, and thermistor, and SpO2 probe, then nasal flow sensor. So what consumables we require to prepare or before our patient? So we need a measuring tape to mark the 10-20 distances, and 10-20 paste, gloves, marker, and new skin preparation gel, and dynoplast, and ECG electrode, scissor. Maybe we record shaver also if patient having like thick hair in the ECG place or in the leg EMG place to get better connections. So next is, now we need to we already discussed it, for the EEG, to record the sleep, we need to connect EEG electrodes. So how to connect this EEG electrodes? So that is based on the system. It's called the 1020 International System. It's an internationally recognized methods that allows EEG electrode placement to be standardized. Most electrode placement sites found 10 or 20% of measurement between anatomical distal landmarks, Nash-Indian, and left preauricular point and right preauricular point. We can see the diagram. So in this diagram, most of our connections are in 10%, 20%, 20%, the distances. So we can see the Nash-Indian, that is a bridge of the nose. And there is a Indian. Indian is occipital protuberance that we can place in your hand, back of the head, and we can feel there is a bony place that is called Indian, and preauricular point that is in the front of ear, above the targus, in the front side of nose, that is called preauricular point. So let's see the basics of 1020 system. We will place the 1020 system EEG electrodes. We will place odd numbers in the left side of the head, and even numbers we will connect in the right side of head. So we can see the diagram. So see FP1, F3, F7, T3, C3. Most of the electrodes are placed on the left side, and FP2, F8, F4, C4, this electrode are placed on the right side also. And Z is the midline. CZ, OZ, PZ, we can connect in the center. So what is this 10? So we have discussed it to connect the EEG leads to record the sleep, brainwaves of sleep. We need to connect 1020 International System. So what is this 1020 system? Oh, sorry, we already discussed it. So next is, for the routine EEG monitoring, we record 16 channels of EEG. So, but for the sleep EEG monitoring, we record only 3 EEG derivations. That is F4, C4, and O2. As per the American Association of Sleep Medicine, so we will connect F4, C4, O2. So for the record sleep, we record only 6 channels. So 3 backup and 3 electrodes. So F3 and C3 and O1. That reference to M2 also. And F4, C4, and O2, this is the backup electrode, and backup with M1 as reference electrode. So why backup is important in the during the study? If there is any malfunction, so we will use it as backup electrode. I hope everyone understand the how many EEG is needed for the sleep. So 3 electrodes. Okay. So how to prepare the site? So make sure electrodes are clean and in good condition, and clean the located sites gently with Neurobiology gel, and apply the 1020 paste, like mark the area then prepare the site, clean with the new gel, then take the golden cup of electrode and fill the golden cup and attach the electrodes and secure with the gauze piece or adhesive tab. So now we have the prepared things, consumables and electrodes for the hookup. So let's see how we are going to hook up. So we have the measuring chart here. The first step is we already discussed there is a four landmarks. There's Nation, Indian, left pre-auricular point, right pre-auricular point. Where is the Nation? This one we can see in the picture. Nation, Indian, and left pre-auricular point and right pre-auricular point and other side. So first locate this marking, then measure the Nation to Indian. So for example, this is a 36 centimeter. So we will mark on center as CZ. And we will mark FPZ, 10% of total distance from the Nation. So Nation to 10% is called FPZ. Then from the CZ to 20% of distance, we will mark as FZ. So we have the chart here. For example, Nation to Indian distance is 36 centimeter. 36 centimeter, we have the chart here. This is the 7.2 is the 20%, 3.6 is the 10%. From next, we will mark OZ. From the Indian, this is the Indian. So from here, 10% distance is 3.6. So upward direction, we will mark 10% of the total distance. That means 3.6 from Indian to, we will mark 3.6 as OZ. Okay, so we can see the diagram. This is the Nation, this is the Indian, and right pre-auricular point, left pre-auricular point. So for example, it's varies different to the Nation and Indian centimeters, varies to person. For example, we took it's a 36 centimeter. So we will mark again. We will repeat this one again. So this is 36 centimeter and this is 34 centimeter. So we will mark this place as CZ. From here to 20% of distance, we marked FZ. From Nation to 10%, we marked as FPZ. From Indian to 10%, we marked as OZ. So next step is we will mark C3, C4, M1, M2. So how to mark C3, C4, and M1, M2? Distance of left and right pre-auricular points. So we need to measure pre-auricular point to right and left pre-auricular point, left and right. We have here already center, and from CZ to 20% of distance, we will mark as C3, and CZ to 20% of distance, we will mark C4. And we can mark M1 in the left mastoid process and M2 in the right mastoid process. This is the exact location for the M2. Okay. So next step is we need to measure the head circumference. So we will measure the head circumference. And for example, this is 58 centimeter. Then we will mark 5% from the FPZ left and right. So we have this measurement chart here. 2.8 is the 5%. From here, 5%. And to right, FP2. Actually, this FP1 and FP2 is not required to connect the sleep EEG montage, but for to connect F3 and F4, we need FP1 and FP2. So in the same way, in the back side also, we will mark OZ to 5% to O1, and from here also 5% O2. Okay. Now we will mark the. So next is we are going to mark F3 and F4. So how to mark F3 and F4? So we have we already marked C3 and FP1 and C3. So first measure the FP1 to C3 distance. This is the FP1 and C3. So we will measure this distance. And for example, this is 14 centimeter. We will mark as center is 7 centimeter. We will mark as F3. Same way, we will mark FP2 to C3. We will take FP2 to C4 distance. So for example, that is same 14 centimeter. We will mark in the midpoint. To get exact location, we need to mark or measure again from F6 to F8 location. So the crossing midpoint is the exact location for F3 and F4. So we have the chart here. We already completed our the 10-20 electrode placement. I hope everyone is aware about how first we took this distance, then we took this distance, we marked as center point, then we marked 20% to front, then we marked from nation to 10% as FPZ, and Indian to 10% as OZ. Then we marked 20% from the CZ to C4. From again, we marked C3, 20%. Okay. Then we took circumference of head, 5% FP2 and 5% FP2. Same here, 5% we took FO1 and O2. So now we are connected to EEG. So this picture is demonstrated like we have now connected F3, F4, C3, C4, O1 and O2 and M1 and N2. We can place the ground anywhere of it. Usually we will connect like in the F set or in different locations. So next we are going to connect to EOG electrodes. EOG electrooculogram to record the movement of eyes. So this electrode are placed outer corners of the eyes. We can see in the diagram, one is in the left and one is in the right. So 1 centimeter outer of the outer canthus and 1 centimeter below. In the same way, we will connect in the right eye 1 centimeter outer and 1 centimeter upside, E1 and E2. So next we are going to connect the electromyogram. That means chin EMG. Why it is important? We need to connect to diagnosis of the bruxism or to understand the stages of sleep. For example, in the REM sleep, maybe the chin movements are very minimal or completely eliminated. But in the N1 or wake, it's a high presence of chin muscles. So how to connect this one? We can connect to the first electrode. We can connect in the midline of the chin, above the 2 centimeter above the inferior edge of the mandible. And another one 2 centimeter below and 2 centimeter outer. We can connect below the inferior edge of the chin. In the same way, right side also 2 centimeter below, 2 centimeter outer. We can connect inferior mandible edge. So next is leg connection. Why leg connection? We need to connect to understand to diagnosis of the periodic limb movement disease or restless leg syndrome, to understand its effect in the sleep. So we need to connect each legs. We need to connect two electrodes in the front of anterior tibialis muscle in the 2 to 3 centimeter of part of the length of anterior tibialis muscle. Next is ECG connection. So we are using ECG to ECG lead to sensor. Lead to ECG, we are connecting torso electrode placement. So one is in the right arm and another one is in the left leg. So additional electrodes we can connect if clinically indicated. So next is snore sensor. We can place in the near to Adam's apple or left or right of the midline. And we need to avoid to place it in the above the carotid artery. And next is thoraco-abdominal belt. So we need to connect one thoracic belt and one abdominal belt. And so the belt should not be too tight or not too loose. And in the thorax nipple level and an abdominal belt, we need to connect in the navel level. So in the earlier, we have used the piezoelectric belt, but nowadays it is outdated. Now we are using RIP technology, respiratory inductance polysomnography. Okay, so effort sensors.
लेफ्ट किया इसमें पूछो भाई सर्टिफिकेट कैसे दोगे तुम वॉइस का
Requesting everyone, please keep yourselves muted.
Okay, so we'll continue. Next is we need to connect the position sensors also. So we usually position sensors we will connect mount with the thoracic belt. We can see in this picture. So we connect the position sensor in the mid of the belt, like near to midline. Okay, why it is important? We can understand the patient is going to optimal titration, like patient is sleeping in the supine position, patient is sleeping in the left side, or patient slept 2 hours in the left side or 4 hours in the supine position. It's also important for the to understand the diagnosis. So next is pressure transducer cannula and thermistor. So we need to connect to thermistor and pressure nasal cannula in each patient. We need to connect both these cannulas. Why? Because thermistor we use it to score only apneas. Pressure transducer cannula we use to score only hypopnea. Okay. So next is we need to connect SpO2 probe and need to attach some tab. Otherwise, it's maybe chance of the disconnection during the moment of sleep. So now we completed the EEG, EOG, EMG, and ECG and other sleep parameters. This is for the final picture after the connections. So we already discussed the preparation of the consumables, what we required, and electrodes and sensors, and 1020 EEG connections and measurements, and EOG connection, leg and EMG connection. We discussed the thoracic and chest abdominal belt, and pressure transducer, cannula, thermistor, position sensor, snore microphone, SpO2. So thank you. I finished.
Thank you, Red. Thank you so much. While Rujuta is joining back and taking over, just a couple of announcements. If you have any questions, आपको अगर कोई सवाल हो, please put them in the chat box for our faculty, and we will take them as and when we can. Please keep yourselves muted. If you have any query, please put it in the chat box. We will take that. And if you've not changed your name, please change it so that we identify you at the end of the day. So that it becomes easier. We have more than 215 participants listening today. It will be very difficult for us to track who is listening. if you don't change your name. So a lot of people who have joined from their iPhone, I can see only iPhone everywhere. Please change your name. Click on your name, rename it to your actual name. Rujuta, over to you, please.
Thank you, ma'am. Thank you so much, sir. We do have a question in the chat box asking if the ETCO2 monitoring in polysomnography. So if you could just mention in brief about it. Okay.
Yeah.
Yeah.
For the ETCO2 monitoring, for the standard polysomnography, as per the ASM, we need these sensors. But for some special cases, we will use ETCO2 monitoring, like in pediatric cases of sleep study or hypoventilation cases. Also, we will use ETCO2, transcutaneous ETCO2, not the standard polysomnography.
Thank you so much, sir, for the lucid explanation. If we have any further queries, we could put them in the chat box and that could be taken up later during the course of the webinar. Thank you so much once again, sir. Thank you.
Thank you.
Moving on to the next webinar, which is on beyond basic special procedures. Unfortunately, due to some medical conditions, Mr. Niaz wouldn't be with us today. However, Rafiq sir would take over the session, so I would like to invite Rafiq sir. Thank you so much for taking up the session, and I understand it was at the last moment. So thank you so much, sir. Over to you, sir.
Hello. Can you hear me?
Yes, sir, we can.
So I'm back again with another topic beyond basic procedures, the special procedures in the sleep lab. So far, we have seen what is polysomnography, what are the assessment techniques we usually use in the sleep lab, and then how all these sensors are connected and to get an artifact-free recordings. Now we will move on to some special procedures which is done in the sleep lab. So the objective of the talk is to make you to discuss about the home sleep studies, which Dr. Samia already had a glimpse of the home sleep study earlier, and to discuss about the multiple sleep latency, another procedure called PAP nap, use of a full montage sleep studies, including RBD montage. So what is home sleep study? So as explained earlier by Dr. Sami, so you are giving the machine to the patient. When a patient comes to you, doctor, physician evaluate the problems and find out that the patient is having high pretest probability of obstructive sleep apnea. In that case, you will give the machine to them. So we can see in the sleep disorders we discussed, there are 7 sleep disorders, major 7 sleep disorders, encompassing almost 82 sleep disorders altogether. So which sleep disorder this home sleep apnea is given, home sleep testing is given? The only one sleep disorder, that is home sleep apnea. So if you suspect the case, the patient is having obstructive sleep apnea, that's the only time you will do the home sleep study. Rest of all other disorders which we discussed earlier, like insomnia, or be it a circadian rhythm disorder, or like a parasomnia, so movement disorders. None of those disorders qualify for home sleep apnea. That's the first home take home message. Second thing, home sleep apnea testing is a rule in mechanism, not a rule out mechanism. What that means? So if you are giving a home sleep testing, you are a 95 to 100% probable that this patient is having obstructive sleep apnea. So if the test turned out to be negative, that means he is not having obstructive sleep apnea, then you are in trouble. You need to go for a full night sleep study, because to begin with, there were some problems which necessitated this testing. All right. So what is the method? The patient comes to the patient comes to the clinic, instructs the patient how to use the device. Patient return the device next day. You download the data and score and generate the report. So what are the advantages of this home sleep study? Is that it is convenient and comfortable, because the patient is doing the test at the comfort of their home. It is very cost effective in terms that it is just like costing you only like 1/4 or 1/5 of the polysomnogram. It is easily accessible. You can have several home sleep study machines in an institute. I don't know whether that's the case in across India, but majority of the hospitals do have more home sleep study devices rather than the polysomnography, because of the cost associated with the sleep system, and reduced anxiety, because there is no many wires. And the patient is always at the comfort of their home. And then increase the patient compliance. The patients are ready to willing to do the test. Of course, it is having disadvantages. What are they? It is limited data collections. You cannot control what all things to be recorded. It's only what all things available. Artifacts acceptability in overnight polysomnogram. We discussed earlier, there are two types, like type 1 and type 2, where there is a full polysomnogram, right? One is type 1 or level 1, where there is a technician is monitoring the recording. So if anything goes out, especially the SpO2 probe, if it is out, you will be able to go inside and reconnect it. But in the home sleep study setting, it is very difficult to figure out that. And then another problem is the patient involvement. So what you're doing is you're teaching the patient how to connect all these sensors. And those patients who is having cognitive problems, or elderly people, teaching them would be a challenge, and patient involvement may make it a bit disadvantageous. Limited suitability, which means it cannot, as I said earlier, it cannot be used for the other sleep disorders like parasomnia, PLMs, or circadian disorders, if at all. And it is only used for. And the potential for false negative, as I said earlier, if this is assuming that the patient is sleeping at home. What if the patient is not sleeping? So we don't have any parameters to record the sleep parameters. So we don't know whether the patient actually sleep or not, actually slept or not. Or in the other case, if the patient doesn't have any obstructive sleep apnea things in report. So what that means, the patient doesn't have obstructive sleep apnea. No, you might have to repeat the sleep test, the full polysomnography. So in short, home sleep apnea is done with the case of a high pretest probability of OSA, and that's it, obstructive sleep apnea. Even if it is you are suspecting chain stroke respiration or a central sleep apnea, you will not do home sleep study. If you are suspecting obesity, hypoventilation, or periodic leg movement, or a neuromuscular disorder, COPD, whatever the case be, you will not do the home sleep. So it is only exclusive to obstructive sleep apnea diagnosis. and it is a rule in mechanism, not to rule out. So what are the signs and symptoms of obstructive sleep apnea? How you know it is this patient is having the high pretest probability. So the patient comes to you with snoring, excessive daytime sleepiness, tiredness, witnessed apneas, then cognitive impairment, morning headache, nocturia, sexual dysfunctions, gasping or choking during sleep. And if, as I said earlier, snoring along with the diabetes is a bad combination. And when it becomes along with hypertension, snoring, diabetes, and hypertension, it becomes the worst combination, and the chance for obstructive sleep apnea is very high. And earlier, Dr. Sapni was discussing about the questionnaires, and which most commonly, excellently, beautifully explained. Most commonly used questionnaires are Epworth Sleepiness Scale, which comprised of 8 situations. In each situation, how likely the patients are falling asleep. For example, as I said, like sitting and watching, sitting and reading, or watching television. Most of the time you feel sleepy, then it becomes 3. Sleep never means 0. And you calculate all together, and it becomes, you will give you a total score, and if something, a score about 10 is considered to be abnormally sleepy. But that doesn't tell you why the patient is sleepy. You might have taken a sleeping medications, or you might be on some other medications which make you sleepy, or you might have a PLM disorder, or you might have a narcolepsy. You don't know why you are sleepy, but you know the patient is excessively sleepy. That's the downside of the Epworth Sleepiness Scale. It is not specific, but it will give us a better understanding of their sleepiness. Then you will do a job bank questionnaire. It is more specific to obstructive sleep apnea. So as explained earlier, it has got a 2 portion, a stop portion and a bang portion. Stop portion, the problem with the ESS is that it is a self reflection. So you are saying, if I ask you, do you sleep during while watching television? You can say no, and then I don't know, I don't have any proof or mechanism to prove otherwise. But in stop bang, it is just like except the snoring part. We will be able to see more of the this area. The stop bang is basically an objective part. Subjective part, bang is basically an objective. We can kind of count the BMI, age, neck circumferences, and gender being male. So if you have a score, something more than 3, there is an intermediate risk for OSA. So the stop bang is basically highly specific for obstructive sleep apnea. So if you do a Epworth Sleepiness Scale, and then you have a high score on ESS and a high score on a stop bang, and when you do a neck size measurement, more than 17 inch for men and 16 inch for women, and with an Mallampati classification, being a respiratory therapist, we all are very aware of the Mallampati classification. With Mallampati, if it is 3 and 4, it's high probability for obstructive sleep apnea, along with some of the other faciocranial features like litrognathia, micrognathia, crowded airways. All these short neck, all these points towards the obstructive sleep apnea. So you give home sleep apnea machine to that type of patients. So far we were discussing about the conventional home sleep apnea machines, which includes the thoracic and abdominal effort, and then flow sensors along with the SpO2 probes. But recently we have some new machines like peripheral, which works on the principles of PAT technology, otherwise called as peripheral arterial tonometry. You can see in the picture, the patient always wear a watch with an SpO2 probe, and then there is another sensor which is connected to the neck part of the sternum, and that's it. It will record your arterial tone and oxygenation and convert it into REI, respiratory event index. So these are the techniques which we used for the home sleep. Now, so as I said earlier, we have 7 sleep disorders, and in which the second one is a sleep-related breathing disorder. And in that, again, we have obstructive sleep apnea, central sleep apnea, chain stroke, or obesity, hypoventilation, respiration, sleep-related hypoxia. None of this will qualify for home sleep study, only obstructive sleep apnea. All right. So now the next disorder we discussed during the sleep disorders was central disorders of hypersomnolence. What that means? So the problem, you are feeling excessively sleepy during the daytime without any problem of, you don't have any sleep-related breathing disorders. You don't have any other problems like parasomnia or sleep-related movement disorder. And your circadian rhythm, everything is, you have a very good sleep hygiene, you go to sleep at a normal time and you wake up at a, but still you feel sleepy during the daytime due to some involvement of the central area, that means the brain. During my discussion, I have shown something about the lateral hypothalamus, which produces a hormone called orexin or hypocortical. The insufficiency or the lack of those hormones produces a disorder called as a narcolepsy. Narcolepsies are of different types, type 1, type 2, then there is something called a idiopathic hypersomnia. So what I'm trying to tell you is that the sleep studies and sleep special testings are based on the sleep disorders. And for the central disorders of hypersomnolence, and if any patient is suspected of having narcolepsy, then the test of choice is called MSLT. So how the MSLT is done? Before going to MSLT is done, what is narcolepsy? There are 4 cardinal symptoms. One is the excessive daytime sleepiness. Let's say instead of saying excessive daytime sleepiness, it is called a sleep attack. All of a sudden, sleep comes, you sleep, and after a few minutes of nap, you just wake up and you feel much relaxed and more energetic. So it is just like 5 to 10 minutes of nap makes you more powerful naps. Okay. And which that sleep you cannot control. That's why it's called a sleep attack. And then there is something called as a hypnagogic hallucination or a hypnagogic hallucination, which is something like seeing vivid imagery. This hallucination is something viewing something it's not real, right? So you see those type of things, you are going to sleep. When you're going to sleep, it's called hypnagogic hallucination. And if you are seeing that things or hearing or feeling or things which are not real, for example, you're hearing somebody talking to you, or you're seeing some ghost or an angel coming into the room, so it's something like that. It's called a hallucination, and it can be a sign of central disorders, hypersomnolence. Then there is something called as a sleep paralysis. What is that? Even though it is called as a sleep paralysis, we discussed earlier, we have an REM sleep and an REM sleep. The characteristic feature between REM sleep and an REM sleep is the muscle tone, as explained by Wright. So that's why we are using the chin muscles, chin EMGs. The chin tone will be at lowest. So during REM sleep, you will dream, for example, you're dreaming that a dog is running behind you and you want to run, you cannot run, right? And why it is happening is that all your muscles, including excluding the eye muscles and respiration muscles and heart muscles, all muscles are paralyzed. That's why you cannot run, you cannot move the hand or something like that. But what happens if there is a central disorders of hypersomnolence, or if you are not sleeping, if you have excessive or better say chronic sleep deprivation, you may feel that when you are awake, oriented, your eyes are open, but you cannot move the legs. So it is just a sort of a REM sleep physiology happening during wake time. So REM sleep attack happening wake just waking up. It's a painful situation. You are awake, you cannot move, you cannot scream. It's a painful situation. So the fourth one is the cataplexy. What is the cataplexy? Cataplexy is the loss of muscle tone to emotion, especially to a positive emotion. So these are the four cardinal symptoms of narcolepsy. So if you see a patient coming to you or to the clinic with these symptoms, other than the obstructive sleep apnea or insomnia, you can suspect this patient is having sleep narcolepsy. Then type is what type is next. So you can see here. Let's see what's happening in cataplexy. So this patient, these kids, you are playing. See, so the muscle tone is lost to the lab. So she's not sleeping. She lost her muscle tone. So what is happening in this cataplexy is that you lose your muscle tone to a positive emotion like laughing, happiness, or sometimes to the anger, sometimes even during sex. So any emotions that makes you loss of muscle tone. So cataplexy in this scenario, what is happening was that they were making fun of this girl, and she started laughing and she started losing her muscle. So what is the test of choice if you have an narcolepsy? So the test of choice is called multiple sleep latency test, MSLT. So what is the test? The test is happening during the daytime. The patient sleeps 5 naps of minimum 20 to 35 minutes. Okay, so it always an overnight sleep study have to be done before doing an MSLT. So if you have a patient with an narcolepsy, the patient will come to the lab. We got all those wires to the head, face, body. Then you will connect to respiratory valves, everything, and then including the leg movements. So all the 4 parameters will be recorded with the video, and you make sure that this patient doesn't have any other cause for having excessive daytime sleepiness, like obstructive sleep apnea or periodic leg movement and so forth. So you did the polysomnography is absolutely normal, but still, and patient slept more than 6 hours or 7 hours as per the requirement. Still, patient feels sleepy. So you will continue with the MSLT during the daytime. So for doing MSLT, you don't need respiratory channels or leg movement channels. Only you need is here the point of interest is the sleep. So we need only the sleep parameters. What are the channels required for the sleep parameters? We will keep EG, we will keep EOG, we will keep EMG, and for the safety reasons, we will keep ECG, and that's it. The rest of the respiratory effort, flows, body position, and the leg movement, etc., will be removed. So when it happens, usually it happens 1.5 to 3 hours after waking up from the sleep study, which means your sleep study, overnight sleep study ended at 6 a.m. You can start the first nap of the MSLT at 7:30 a.m. or it can be up to 9 a.m. Usually it is started at after 2 hours. Okay, and then you will make the patient sleep again a second nap after 2 hours. So in this example, given example, the patient will be having a nap at 8 a.m., 10 a.m., 12 a.m., 2 a.m., sorry, 2 p.m., 2 p.m. and 4 p.m. 8, 10, 12, 2, and 4. So 5 naps is usually done. How long the patient will sleep? Patient will sleep, will be given opportunity to sleep maximum of 20 minutes. If patient falls asleep within that 20 minutes, the patient will be given opportunity to continue sleep for another 15 minutes to see whether there is any sleep happening or not. So this is what is the nutshell of MSLT. So MSLT is done to find out whether this patient is having narcolepsy or not. If not narcolepsy, then it could be an idiopathic hypersomnia. How the test is interpreted. So test is interpreted if the mean sleep latency, that means the how quickly he fall asleep in sleep 1, and how quickly he falls asleep in sleep nap 2, nap 3, nap 4, and nap 5. Altogether, take it and average it by the number of the naps, and you will get a mean sleep latency. If the mean sleep latency is less than 8 minutes, we can say the patient is excessively sleepy. So what next? So there are two characteristics we are looking in an MSLT. One is the mean sleep latency, and the second one is the presence or absence of the REM sleep. It is otherwise called a sleep onset REM period. Within those 15 minutes, whether the patient entered into the dreaming sleep or not. Interestingly, the patient with narcolepsy will have more than 2 REM sleep during those 15 minutes of sleep. So if the mean sleep latency is less than 8 minutes, we can say the patient is having excessively sleepy. Next, you will look whether the patient is having 2 or more SORMs in the 5 nap, or if you have a 1 SORM in the nap and then 1 SORM in the previous night PSG, you will call it as a narcolepsy. Now the question is whether it is a narcolepsy type 1 or the narcolepsy type 2. How it is being differentiated? We know there are 4 cardinal symptoms: excessive daytime sleepiness or the sleep attack, and then hallucination paralysis. And the differentiating feature is the cataplexy. In type 1, you will have a cataplexy, and type 2, you will not have cataplexy. Again, have some testings can be done by using the hypocretin level. If it is less than 110 microunits, it is very confirmatory for type of narcolepsy. So there are some instructions to be followed. The medication should be on stop, for example, REM suppressants. Most of the antidepressants, be it tricyclics or SSRIs or SNRIs, whatever, those medications has got very important role in the sleep architecture. So antidepressants is notorious to cause REM suppressing, so that if you are on antidepressants, you will not have REM sleep, and then there is no point of doing the MSLT. So it should be on hold for at least 2 weeks. And then there are something called as a stimulants like diphenhydramine or modafinil. These drugs should be on hold for 3 to 4 days, so that there is no excessive awakening. So and there should be a drug screening of urine drug screening before the MSLT, and the caffeines should also be respected. So that's an action of the MSLT. Then there is something called as an MWT here. What in MSLT we are checking how quickly he falls asleep. You are instructing the patient try to sleep. But in MWT, you are keeping the patient awake and maintaining how long the patient can stay awake. So this is mainly done in airline pilots or the long distant truck drivers, things like that. So they want to make sure that to keep their job safe, they need to make sure that they are able to be awake during the daytime. And this is a required test for such type of service people. It's not usually done. It is basically a test to prove that you are able to be awake during the daytime. MSLT, on the other hand, is a test how quickly you fall asleep, and to diagnose and name to associate a PAD, whether you have an narcoleptic or an idiopathic hypersomnia. If going back to the MSLT, if you don't have two SORMs, but still mean sleep latency is less than 8 minutes, that means you are excessively sleepy, and that situation you will be tagged as a narcolepsy is a dreadful disease, and it is very commonly seen in teens at an age. It can seen, but usually it is in the college school teens. Then there is something called as REM sleep behavior disorders. Now, earlier we discussed that during REM sleep, all your muscles are paralyzed. So you are seeing a dream and you cannot act on it, right? So you are seeing a dog running behind you, but you cannot run. Why? Because all the muscles are paralyzed. And that is a protection from the god not to act on your dreams, right? But in RBD, what happens is that that protection is lost and all your muscle tones are active. So what you do is you start acting on it. So you can see in this one, he is dreaming something, and he start kicking and throwing and shouting. This is very dangerous situation where the patient harms himself. He may fall asleep, may fall out of the bed and may damage himself, and we have several cases like that. And then there is something called as so the patient may be dreaming that he is playing football and he is taking a very big kick. In fact, he may be kicking the back of his partner or head of his partner, right? So it is a problem for the so so in that case, what you do is additionally you have to connect as well, so that sometimes you see this arm movement. So you can see here, this is a classic REM sleep. You can see in the eyes. Why you see while dreaming, you are always moving your eyes up and down, left or right. So that's why we are saying we saw a dream. To see, you need to move your eyes, right? So you can easily appreciate it when you look at the infants. The moment they go to sleep, they start moving their eyes and start smiling. And so that means usually infants go to sleep, start sleep with a REM sleep. And that's why they are having this eye movement and then smiling, things like that. So what happens during REM sleep is that you will be moving your eyes rapidly. At the same time, your chin tone will be at the lowest. But in RBD, what happens is that this is an example of an RBD patient. Here you can see the chin tone is very high, and the leg tone is also high. You can see very high. It will be very difficult if you are not an experienced guy to differentiate it whether it is awake or. Next is a nocturnal seizure study. We have seen the other sleep type of disorders in the classification of sleep disorders. You can see that sleep-related epilepsy is one of the sleep disorder associated with that. So in that case, what happens is that we need to connect full EEG leads as in contrast to the most commonly connected sleep EEGs. Right, beautifully explained about the most commonly connected sensors, which are the F3C3O1, then F4C4 and O2. So the right side is most commonly used for the scoring purpose, and the left side is commonly used as a backup. But if you are suspecting a seizure patient or something like that, you might have to involve all these areas. All the EEGs needs to be connected in all these areas. And this is an example of a montage where you connected all the EEGs. You can be. I know there are several EEG techs here listening to this talk, and they will be more appreciating. So that they have called as anterior posterior longitudinal banana, double banana montage. and then oblique montage, referential montage. There are different types of montages. And this is an example of a 30-second window of an event which is showing spike and slow wave, which is usually seen in seizure patients. You can see here, there is no phase reversal though. All right. So far what we discussed about the home sleep study. We discussed about the MSLT, MWT. We discussed about the nocturnal seizure montage. And another one is the PAP nap. So this is also a type of a sleep study, abbreviated cardiorespiratory study where it is done for those patients who have difficulty in tolerating a CPAP machine. The next talk, Sulochana will be discussing about how to get an optimal CPAP titration, and then following that, Salwa will be talking about how to teach the patient to use it in a way that they are compliant. But there are patients, whatever you do, there are patients who cannot tolerate the machine. So we can bring them back and then give them a modified, good teaching, and then making the patient to utilize it in a way that it is comfortable for the patient. So this is a 2 to 3 hour program in a sleep lab where you will be doing mask fitting, desensitization, what mask is good for the patient, and then acclimatization techniques. For example, if you will be selecting types of the mask. Wide variety of masks are available from different manufacturers, and we find out which mask is more comfortable for them, and we are making the pressures increasing from 4, starting at gradually at 4, increasing 5, 6, 8 to 8. Once you get a pressure up to 8, you will be able to understand the heat. And then you give them a patient an opportunity to nap. That's why it is called a PAP nap trial. And then to make sure that the patient is able to find out he can tolerate the CPAP in a way that it has to be done. So in short, what all things we discussed, home sleep study is discussed, MSLT, MWT was discussed, RBD montage, seizure montage, and then PAP nap. And thank you. If you have any questions or concerns, let me know.
Rujita?
Over to you, Rijita or Madhuri.
Yeah, I think there was some question. While Rujita is joining us back, let me take that question for you. I can scroll all the way up to the questions. Rujita, do you have those questions written?
There was one question on ABG, ma'am.
Yes.
Second.
Can ABG be taken during sleep study
Yes.
and after complete study to reveal OHS?
One second. Sorry. So the question was, can ABG be taken during the sleep study, right?
Yes.
So what do you think? Can ABG be taken during a sleep study? The simple answer is yes, but is it the recommended one? How many times you might have to take an ABG to get the CO2 level? So for that purpose, somebody was asking earlier, I think it's Shahalas asking to Ryan, the use of transcutaneous carbon dioxide machines. We can connect it to get a surrogate of the CO2 levels, or you use something called as end-tidal carbon dioxide. If you're doing a diagnostic study, you will be able to do the end-tidal, and if you're doing a titration study, you will be you need to use the transcutaneous to get the surrogate. But there are centers or there are physicians who need to see ABG prior to the sleep study and after sleep study. It can be done, but doing ABG during the sleep study when the patient is asleep, it's not recommended. If not, you have an arterial line.
Yes. Thank you so much, sir. I really appreciate the effort that has gone into presenting two presentations, especially. So thank you so much. I think it means a lot to all of us, and I'm very sure that all the delegates, by the end of the session, have quite better understanding and a clearer picture of the polysomnography. So once again, I would like to thank you on behalf of the Maharashtra Regional Committee, and thank you very much for being here today, sir. It's a privilege to have you with us.
Thank you. And I consider it's my honor to be talking to you. And once again, thank you, Maharashtra Committee and IARC and Slojana for coordinating all this.
Thank you so much.
Yeah.
Next, we have our very own Miss Sulochana, who is the master brain, I would say, behind this whole workshop that has been together. I have seen her work really hard over the past fortnight, trying to put things together and trying to make this webinar possible. So thank you so much, Sulochana. And she is here to take us through a very interesting topic on the CPAP titration study. So Ms. Sulochana holds a bachelor's and a master's degree in respiratory therapy from the Symbiosis Institute of Health Sciences, Pune. She is also a PhD scholar with the Chettinad Academy of Research and Education, Chennai. Presently, Ms. Sulochana holds the Division of Respiratory Therapy at Bharati Research Hospital and Research Center, Pune. So we are really obliged to have you with us, ma'am, today, and I would request you to take over the session. Thank you very much.
Thank you so much, Rujuta, for the kind introduction. So I can see we have very less time left. So without wasting much time, I'll go to my topic. Let me make it little more interactive. Okay, so I know you might get scared, but can you see my screen? Is it visible to everyone?
Yes, we can.
Okay, great. Okay, so what about this graph? This is the entire polysomnograph. Actually, how does it look like? So here you can see if you all these things has been already covered. So I'll just give you a brief of it so that it will be easy for me to make you understand like what exactly I'm going to deal with. So these are the EEG waveforms. Then we have LOC and these are the ocular graphs basically. Then this is the chin electrodes which is showing the graph. Then there are EKGs. Then there are so many EKG, EMG, everything. But what is important for you to understand in this graph is from here. Okay. So for us, it is important to, yeah.
No,
Sorry.
you can continue.
Okay. Yeah. Okay.
So
for you,
sorry, Sulochana, do you want to make this full screen? Yes, thanks.
yeah. Okay. So for us, I want you to focus on from here, these graphs. Snore, C flow, which is CPAP flow. Okay. Nasal airflow. Then this is the basically thoracic and abdominal belt, which Red was talking about. So this will indicate your respiratory effort. Okay. And the saturation part. Okay. So this is where we will focus. And looking at these graphs from nasal airflow and then CPAP flow, then the snoring and the effort. And important thing is this saturation. Based on this, we can decide the titration. Okay. So now let us start from the beginning. I hope now things are clear that we are going to deal with a complex graph. So I want you to please pay attention to this. Okay. I just wanted to minimize this. Yeah. Okay. So before going ahead, I would like to give you the overview what exactly I'll be dealing with. First is indication of starting a PAP therapy. Then what are the various PAP interfaces that we often use for titration studies? What is a PAP mechanism? Then choosing your appropriate PAP device is also very, very essential. Then we will learn about the titration protocols for CPAP and BiPAP titration. And yeah, that was just the case study which I was showing you. So please pay attention because it is you who has to answer once I am done with all these things. Okay, and last I will cover with, I will deal with oxygen supplement in PAP titration. Okay. So we already know that positive airway pressure is basically the treatment choice for those patients who have moderate to severe OSA, okay, obstructive sleep apnea, and it is an option to be used in symptomatic patients with mild OSA, okay. Because in mild OSA patient, you can also go for this automatic CPAP titration studies. But for mild and for moderate and severe OSA, you are supposed to do manual titration. Okay, that's why we are here today covering all those topics. And throughout the titration study, patient is supposed to wear the PAP device. Okay, and there will be a sleep technologist or a respiratory therapist throughout who will observe the polysomnogram and looking at that polysomnogram. Just now I told you there was these are the two important sections. One is respiratory event, which I told you that those are the important graphs which you will be monitoring during the titration study, and the sleep disturbances. Sleep disturbances, you can see it in the EEG graph. So in EEG graph, for you, it is important to identify and score REM sleep and whether there is an arousal during the entire sleep because of these respiratory effort related disorders. Okay, so based on these two things, respiratory event and sleep disturbances, your sleep technologist or respiratory therapist, they will decide the PAP pressures. Okay, and that's how titration is being done. But most important is what? Your patient should be aware and he should be educated well about the titration study, because he should not feel, because see, putting a PAP device over somebody and on somebody's face and asking them to breathe through that pressure, against that pressure, is very, very difficult. Okay, so PAP education and patient orientation is very, very essential before doing the titration study. Okay. So what are the treatment objectives basically? Why are we giving PAP therapy? What will happen if you'll give? So basically the objective is to reduce this daytime sleepiness and other daytime symptoms, okay? To reduce complaints such as snoring, choking, gasping, stopping breathing episodes, okay? Ultimately improving the quality of life and not the least decrease long-term cardiovascular consequences. So ultimately what will happen, the goal is to reduce the morbidity and mortality and improve the quality of life of these patients. Okay, so I could see somebody asked it in the chat box, what are the indications? Okay, so the indications for using PAP therapy is what it is. First, now you are aware of apnea hypopnea index and RDI. I'm sure you know about this. What is apnea hypopnea and what is RERA? So I assume you know all these things. So if the AHI or RDI index is more than 15 events per hour. So in 1 hour, if you see more than 15 apneas or hypopneas, okay, it is index basically. So with doesn't matter even if the patient doesn't have any symptoms, but if the AHI is more than 15 per hour, then the patient is supposed to undergo titration study. What if the patient has less than 15 events per hour, but it is more than 5? Then in their cases, you are supposed to evaluate their symptoms also. Okay, so if the AHI is more than 5 but less than 15 events per hour, along with these symptoms like excessive daytime sleepiness, hypertension, coronary artery diseases, etc., then those patients are also eligible for titration studies. But it is mandatory for all pilots and all drivers, even if their AHI is between 5 to 14, without any of these symptoms, they are supposed to undergo titration study. Okay, or if a patient doesn't have apnea and hypopnea but has RERA only, okay, which is respiratory effort related arousals. So if the RERA is more than 10, and along with that patient is complaining of excessive daytime sleepiness, then in that case, you are supposed to do titration study. So just to give you a gist, here you can see what is called mild, moderate, and severe. So as per ASM guideline, the sleep study is basically categorized. There are two types of guidelines. One is for adult and one is for children. So adult more than 12 years, okay, and children, those who are less than 12 years of age, if their RDI or AHI index is between 5 to 15, then it is considered as mild OSA. Okay, moderate OSA, obstructive sleep apnea, if the AHI is between 15 to 30, and severe if it is more than 30. Similarly, in children, it is, yes, it is of course lesser than them. Exactly half of it. So it's like if the RDI is between 1 to 5, then it is mild. Okay. If it is 5 to 10, then moderate OSA, or if the AHI or RDI is more than 10 events per hour, then it is considered as severe OSA. Now, why it is important to know in children? Because nowadays you can see the obesity rate is increasing among children also, because thanks to the pizza, burger, and everything. Okay, so it is very, very important to know that if your child or somebody's child snores in sleep, or if they have this apnea, they undergo apnea phases in sleep, then they are supposed to see a doctor, okay, and get it evaluated properly. Okay, so now before starting PAP therapy, there are certain things which you are supposed to know. You should know the background, like what interface you will use, okay, which device you will use, at what pressure you will use, and whether oxygen supplement is really required for that patient or not. Okay, similarly, like for before getting spectacles, you go and get it checked through a like eye specialist, right? And then you go to a optometrist to get your eye checked first. So they will put a solution, and then first they will ask you to read everything, whether you are able to clearly see it or not. So, and then finally you get the prescription of your specs. So similarly for PAP also, positive variable pressure also, it is similar. You should know what kind of interface you will use, what device you will use, what pressure you are supposed to use, and what supplements, whether supplements are really required or not. Okay. So we already know that there are these various PAP interfaces that we use, like oronasal mask, or simply nasal mask, or nasal pillows. There are various mask available, interfaces available in market now from various companies. But the important thing is the selection. Mask selection is important. Mask selection depends on the shape of patient's face, okay, whether they have facial hair or not, the patient's ability to breathe through this through his nose or not, okay, and patient's preference also. Okay, because most of the patient, if they will be claustrophobic, then you cannot give them oronasal mask in that case. Okay, so that's how we do the selection of the device. Now, what is the mechanism of PAP? So, mechanism of PAP is basically based on the principle of resistance. Now, when you ask a patient to breathe against the pressure, okay, so it creates a resistance, backflow basically. So because of that backflow and resistance, it causes a pneumatic splint. Pneumatic splint means, see here, now in the airway, which will open up the airway and it will not allow it to collapse. Okay, so now here in this graph, you can, in this picture, you can see here, this is the base of the, this is the tongue, this is the base of the tongue, okay, and this is your soft palate. So when you are giving high pressures or positive airway pressure, what happens is, because of that pressure and because of the resistance, it will lift the base of the tongue and soft palate, which will create a gap. Can you see here? This gap. This gap will remain patent throughout the night. Okay, since patient's muscle tone was already very low, and during sleep it further goes down. So now, because of CPAP application, this will generate a pneumatic splint here, which will open up the airway, and patients ultimately it will increase the lung volume, which is basically FRC. Okay, and it will prevent the airways from getting collapsed. That is the main mechanism of positive airway pressure. Okay, so it also may increase the upper airway size, or it will stiffen the upper airway walls, which will make them less collapsible, and it will prevent apneas from happening. Okay, that's how your PAP device works. So we know that in CPAP there will be only one pressure which will be going throughout, like during inspiration and during exhalation also. But in BiPAP, you will have two different pressures. For inspiration, there will be a higher pressure, and for expiration, there will be a lower pressure. Okay, so we will deal it with all these things later on. So now, what type of device should I choose? Should I go for the basic devices or should I go for the advanced devices? It is completely based on the titration and affordability, patient affordability also. Okay, and most important is patient's condition. Okay, so basic devices are CPAP devices, BiPAP. In BiPAP, spontaneous mode BiPAPs, actually they come under basic devices. Flexible PAP. Now I will deal with it. What exactly is called as flexible PAP, and I will explain you clearly. Expiratory pressure relief, expiratory pressure relief devices, or auto CPAP. In advanced devices, we have auto BiPAP, BiPAP with ST mode, which is spontaneous by time mode. Okay, adaptive servo ventilation. So you will deal with all these things when you will come to know about time stroke, respiration, and central sleep apnea. So we use it in those patients basically, and AVAPs. Okay, which is nothing but the backup tidal volume in BiPAP aid. Okay, so I was talking about, I told you about, I'll tell you about this flexible PAP and expiratory pressure relief. So this is what it is. CPAP. So what happens now? Here, can you see here? This is the actually picture of a PAP device. You can see here something mentioned as pressure of 4. Ramp is auto, EPR, C-flex, and forget about autostat. But can you see these two terminologies? What exactly it is? It is nothing but, see, in CPAP, what we have is, we have a common pressure. We have only one pressure throughout inspiration and expiration. Now, just try to imagine, is it easy? See, breathing in is still easier, but exhaling out becomes at same pressure becomes very difficult because you have to exhale out against a very high pressure. Okay, so sometimes because of this high pressure, so if you are keeping a CPAP of 8, 10, 12, 15, and do you expect your patient to exhale out with that high pressure? It is very difficult for them, and they might actually, it will be, since it will be uncomfortable, so patient will complain and they will say that we are unable to sleep properly because of the high pressure. So basically, they will wake up from the sleep. So to make it easy, manufacturers have developed something called a C-flex. Okay, C-flex or A-flex or EPR. These are the definitions which is mentioned here. So this is what, this is the pressure. The pressure will drop down during exhalation basically. Now see here, during inspiration, the pressure is almost around, let's say for example, 7. Okay, so during inspiration, your pressure is remaining 7, but during expiration, since the pressure is very, very high and patient is difficult to exhale out during that expiration, so your pressure is slightly dropping down. Okay, it is slightly dropping down, and then while inspiration, next inspiratory cycle, again your pressure is increasing. So this is not BiPAP, this is your CPAP with C-flex. So C-flex is basically designed to make CPAP therapy more comfortable for patients with obstructive sleep apnea. So it will slowly, if you have switched on your, so you see now here, when your C-flex is on, and your pressure is, for example, your pressure is 4, but ideally it cannot function on 4 pressure. The pressure should be more than 6 or 7. So if, for example, if your pressure is 6 and your C-flex is on, so during inspiration, your inspiratory pressure will be 6, your patient will be breathing at pressure of 6, and during exhalation, your pressure will slightly drop down to 6 or 5 maybe. So you can keep a C-flex on, like C-flex of 1 or 2. You can go maximum till 3. Okay, it will not go beyond that. So I hope it is clear for you. Okay, so but in BiPAP, what happens? BiPAP, you have different pressures already. So your patient will breathe in at this inspiratory pressure, and again your pressure will drop down till this expiratory pressure. So this is entirely different, and the difference between IPAP and EPAP will determine your tidal volume, which is nothing but your through the pressure report, your tidal volume will be decided. Okay. So now to make it easy for you, I have mentioned here everything that there are different terminologies. You might get confused. What is C-flex? What is A-flex? What is EPR? So C-flex is basically used in all respironic CPAP machines. Okay. A-flex is used for automatic CPAP machines. Okay, and EPR, which is expository pressure relief, it is used by ResMed CPAP machines. Okay, so this was the main thing which I wanted to explain you so that it will be easy for you to understand further things. So what is the basic goal? The goal is to eliminate all the goal of the PAP devices is basically to eliminate all the apneas, hypopneas, reras, and snoring. But eliminating everything is not possible, practically not possible. So there is a standard. There is a standard that it should come down till less than 5. Okay. Then we can say that yes, we have achieved our goal. Our titration is adequate or optimal. Okay, we can talk about all these terminologies later on. So this is the goal of PAP therapy. Okay, so now when it comes to protocols, I told you the protocols is different for CPAP titration and for BiPAP titration. So what exactly it is? But before going ahead, you should know that there is something called as full, you can do the titration throughout night. Like for titration study, it is very important to have a full-fledged polysomnography done first. So first you will do your polysomnography, then you can do your titration study. So it's up to you whether you want to do it a full night sleep study, full night titration, full night PSG first, and then titration on the second day, or that is called full night sleep study. Or in the first half, you will do the PSG, and you found out that your AHI is already more than 30. Then you suddenly decided to directly on the second half of night, you decided to jump it for titration study. Then that is called a split night study. Okay, and sometimes patient for mild OSA, I told you for mild OSA, you can give them home auto CPAP device, and you can ask those patients to wear those masks, and your clinicians actually can ask to get the data of that CPAP device after 2 weeks, or let's say 4 weeks, depends on entirely on the from the clinical point of view judgment. Okay, but the titration study is, we know that for titration study, first thing that you are supposed to choose is CPAP only. Then only you can go ahead with BiPAP titration. So CPAP is always the first line therapy of OSA. Okay, or for treating OSA. And what does CPAP do? CPAP, that continuous positive airway pressure, will cause the resistance and it will split open the airway. So basically, splitting up the airway will reduce the apnea. So that is what is our goal. Okay, so CPAP device uses a pressure to split open the airway and prevent the airway collapse. That is what is our goal. Okay, so through that goal, now here you can see that this is normal respiration waveforms. Okay, in RERA, which is respiratory effort related arousals, you can see the graph forms. There is a flow which is happening, but it is slightly on the waveforms are comparatively short in height. Okay, similarly in hypopnea, the waveforms you can see the airflow which is going through the nose and mouth is slightly reduced again, but during obstructive sleep apnea, you can almost see that the graphs have got reduced drastically. Okay, and sorry, my battery is running. Sorry for the interruption. Okay, and in central sleep apnea, there is a complete cessation. There is no respiratory flow happening here at all. Okay, so now what is the titration algorithm says? So this is essential to understand the case study. So please, I want everyone to focus on this slide. So how titration is done for an adult patient. So for an adult patient, for example, I told you CPAP is the first thing that you're supposed to start. Okay, so if you have started a CPAP of 4 centimeters of water, okay, and after 5 minutes, okay, more than or equal to 5 minutes, you saw that, remember, this is adult patient. So adult patient, this is the guideline. Okay, this is very essential. 2353. It means what? If there is more than 2 obstructive apneas or more than 3 hypopneas or more than 3 reras, it is not and, it is or. Okay, doesn't matter if your patient can have apneas, or if it doesn't have apnea, then don't think that your titration was already done. No, you have to look for hypopnea, or if there is any rera or not, or if there is loud snoring or not. So what is the criteria? So within that 5 minutes, at pressure of 4 centimeters of water, if you see that there are more than 2 or more than 2 obstructive apnea, or more than 3 hypopnea, more than 5 RERAs, or more than 3 minutes of loud ambiguous snoring, then you can increase your pressure from 4 to 5 centimeters of water, or you can directly jump to from 4, you can jump to 6 also. Okay, so it should be minimum 1, but you can always go beyond 1. Like if you don't have that much time, you want to increase it further. So from directly from 4, you can jump to 6 also. Okay. Now again, at pressure of 6, you wait for some time. You wait for 5 minutes and again try to look for these obstructive apneas, hypopneas, 5 RERAs, and 3 minutes of loud snoring. If any one of them is present, it is again an indication to increase the pressure further. Okay, so again you have increased the pressure from 6 to 8 now, for example. Now you are at CPAP of 8, for example. Okay, at CPAP of 8, you you didn't find any apneas or hypopneas or RERAs or snoring. So you will observe for 30 minutes. Now wait for half an hour and look for the pressure again. Check that whether he is getting any, he is having any breathing events or not. Okay, so let's say, for example, now you have waited for 30 minutes, but now you are not getting any respiratory events. Then what you are supposed to do? Whether that 8 pressure is adequate, whether it is sufficient, okay, or whether you can consider this as your optimal pressure or not. So what we will do is, you can try to explore further. So you can think that, okay, now should I go with pressure of 9 and check if he has some other events or not. So you can increase from 8 to 9 to 10, 11, like that. Okay, and but maximum limit should be only 5 centimeters above the pressure where you stopped before, like 5 plus 8. Okay, so it is 30. That is the maximum which you can explore. Okay, that is the maximum pressure that should be explored. But for example, there are other patients where you can see that their pressures, they are still, it is already 10 centimeters of water or 12 centimeters of water, and still they have apnea and hypopnea, which is continuing. So you can extend that pressure till 15 centimeters of water. So after 15 centimeters of water, you can think, if at even CPAP of 15 centimeters of water, still patient is getting respiratory events, then in that condition, you can think of switching to BiPAP. But as per AARC guidelines, you have seen that because of different ethnicity and patients' BMI status. For example, if a patient is very hefty, then we have seen patients like they tolerate pressure of 16, 17, 18 also. Okay, so in that condition, the recommended maximum CPAP pressure for those kind of patient is 20 centimeters of water. Okay, so after 20 centimeters, you are supposed to switch back to, even if you get respiratory event at 20 centimeter water pressure, you're supposed to switch back to BiPAP. Okay, so now here what we have done is we have increased the pressures by 2 and 2. So it was 4, then suddenly I increased it to 6, and then suddenly I increased it to 8. Okay, now there was no event, and then I tried exploring. So my total pressure is 13 now. So what I will do? I will try to think of back titration. I may think that, okay, I don't know whether at 8 actually all the respiratory events were stopped, or it was 7. So what I will do in that condition now? So I will try to back titrate it, down titrate it. Down titration means now you will see here, you will start reducing the pressure from 8. Let's say I will reduce it to 7 now. If you have reduced it to 7, then wait for 10 minutes to see the respiratory events or not. Even if at 10, at 7, you are not seeing any respiratory events, you can further decrease and you can wait till you see the re-emergence of breathing events. So this is how you are doing. So you are escalating the pressures and then exploring, or you can down, then at that particular pressure, you can start decreasing, and then you see the re-emergence of those respiratory events. So you see both of these things. That's how, then you will be able to understand like what exactly is the adequate pressure or optimal pressure for optimal PAP, actually, positive airway pressure for this particular patient. So this is not mandatory. This is when we do only when you jump your pressures directly from like instead of increasing by 1 centimeters of water, if you directly increase it by 3 or 4 or 2, something like that. But more than 1 centimeters of water, then only in that condition you are supposed to do down titration. Okay, but again, 1 centimeter of water is always the increase in pressure by 1 centimeter of water is always the recommended guidelines. Okay, I hope this is clear. Similarly, for pediatric patient also, you have to follow the same protocol. Only the guideline, only the difference is what? The number of apneas that you're supposed to see. So in adult, it was 2353. In pediatric, it is 1131. 1 obstructive apnea, 1 hypopnea, 3 rara, and 1 minute of loud snoring. So if you observe any of these things, you are supposed to increase your blood pressure. Okay, and do the titration. Okay, so to gist it up, this is the summary of that thing. So if your patient is a pediatric patient, then minimum CPAP pressure that you're supposed to start is 4 centimeters of water and maximum is 15. In adult patient, minimum CPAP that you can start is 4 and maximum that you can go is 20 centimeters of water. Okay. And when should you increase? And always, yes, I told you, that the recommended guidelines is that increase in pressure by a minimum of 1 centimeter of water with an interval of no less than 5 minutes. Okay, and you have to look for this in pediatric patient. You have to look for obstructive apnea, 1 obstructive apnea, 1 hypopnea, 3 rara, and 1 minute of loud snoring. For adult patient, 2 obstructive apnea, 3 hypopneas, 5 raras, and 3 minutes of loud snoring. Okay, this is important for you to understand. So I was talking about something about optimal titration, good titration. Okay, so the optimal titration is when your RDI index, it reduces to less than 5 per hour for a period of at least 15 minutes at the selected pressure. Okay, so if your, for example, if your patient's RDI in the beginning or AHI was, let's say 30, okay, so to call it as optimal, when you did the titration study overnight, okay, so to call it as optimal titration, your total AHI on that particular pressure should be less than 5 per hour, okay, with a period of at least 15 minutes of proper sleep, okay, sleep basically. The saturation should be more than 90% at that selected pressure, and also there should be a supine REM sleep, okay, at the selected pressure, and it should not be interrupted. So this supine REM sleep should be basically for at least 15 minutes. That is what is recommended, okay, and it should not be interrupted by any spontaneous arousals or awakenings. Whereas, what is good titration? Good titration is there will be times when you will not be able to achieve RDI of less than 5 per hour. Okay, but even though if your RDI has come down to less than 10 per hour, okay, or it has reduced to less than 50% from the baseline, when the baseline was like RDI was 15, less than 15. So in their cases, if for example, if your patient has a RDI in the beginning as the patient's RDI or AHI was 15, okay, so in their case, to call it as a good titration, on that particular pressure, the RDI should be around 50% of 15, which is 7.5. So if your RDI has come down to 7.5, then you can call it as good titration. Or for those patients whose RDI was 30, for example, in the beginning, and now after using titration study, your RDI has reduced to less than 10, let's say maybe 9 or 8, then in that case, but it is still more than 5. So that will be called as good titration, but not optimal titration. Okay. And again, but these 2 points remains the same, that your saturation should always be above 90% and your patient should be able to achieve 15 minutes of REM sleep without any interruption. Okay. So I hope I am clear about these 2 definitions. Okay. Then comes the adequate titration. Adequate titration, your patient, you may not be able to achieve less than 10 RDI per hour. Okay. But if your RDI has reduced to 75% from the baseline. So for example, here, if your RDI was, let's say, for example, 100. Okay. So it should, from 100, it should come down to 75% from the baseline. It means from 100, it should come down to 25 RDI per hour. Okay. So if it is still more than 10, in no range of less than 5. Okay. So in this case, you can call it as adequate titration. Okay. And unacceptable is you haven't achieved any of these titration. So that will be called as unacceptable titration. Okay. And in adequate titration, there will be times where you will not be able to see REM sleep at all. So if you are throughout your sleep study, titration study, if you couldn't sleep, you couldn't get any REM sleep in that entire titration study, then you will call it as adequate titration. So now let us discuss about the case study. So here you have a 45-year-old male patient who is complaining of snoring and daytime sleepiness. Okay, he underwent a diagnostic study and was found to have obstructive sleep apneas. Okay, with an AHI of 65. So what you should do now? So I'll show you his. This is 30 minutes, 2 minutes epoch basically. So this was his case study. This was his PSG, polysomnography. Here you can see patient head is here. He was sleeping in right side. Okay, right lateral basically. This 2, 1, 2, 2 is your sleep stages. This is your snoring. So when he was sleeping in right side, you can see here he was snoring a bit. Okay, these are the waveforms which indicate snoring. Okay, but look at the nasal airflow. That's what I was telling you in the beginning. Nasal airflow. Here you can see some waveforms, but here the waveforms are almost absent. Okay, it is flat. Okay, and if you look at the thoracoabdominal movement and the flow, you can see it is highly reduced, almost reduced. And if you look at the saturation, see here, saturation was almost dropping to 84, and then gradually it started increasing to 90, 95. Again, when he had apnea episode, there was no airflow through the nose. Then at that time, again, the saturation started dropping and it dropped down till 82, almost, sorry, 76, 75, like that. Okay, so the saturation is dropping whenever your patient has these cessation of airflow. So this means what? This patient has apnea. Okay, and because of that apnea, your patient's oxygen is dropping down. So what you should do next? So what we will do as per the guidelines, you have to go for CPAP titration. Okay, so you initiated CPAP of 5, but again you saw that still patient has apneas. So what you did, you increased it to 6 centimeters of water. Now see here, this is the waveforms for 6. Now here, can you see here? Now I have applied CPAP. In the previous graph, there was no CPAP applied here, right? But here you can see CPAP. I have applied CPAP of 6 here. Now my patient is sleeping in supine position. Okay. Still it is a non-REM 2, non-REM 1 stages. Okay, now let us look at this graph. So is my patient snoring? Yes, I can see the snores. Even though if my patient is on CPAP of 6, patient is still snoring. Okay, now let us look at the CPAP flow. CPAP flow here during these snores phases, you can see that it is slightly reduced. Okay, and look at these waveform. When patient was not snoring, the CPAP flow was quite good. Even the nasal airflow was quite good when he was not snoring. Okay, but then again it started when he was snoring, the airflow was highly reduced. It means that patient still has apneas. Okay, so what we will do? We will further, sorry, this was slightly reduced here. So this is hypopnea. This is not complete cessation, right? This is hypopneas. Okay, here I can see this is somewhat apnea here, hypopnea here, hypopnea. So what I will do next? I will increase the pressure further. So now from 6, I increased it to 8. At 8, what you can see, now look at the C flow graph. The C flow graph looks absolutely perfectly normal. Okay, it means now my hypopneas are also not there. There's no apnea at all, but I still can see snoring over here. Okay, and look at the saturation. Sorry, I forgot to tell about the saturation. Here, when I applied CPAP of 6, my saturation went up, but still it is 89, 88. This is what I can see here. So again, it is an indication that I should further increase the CPAP. So when I increase the CPAP to 8, my saturation has started improving, and now throughout the night the saturation was almost around 88%. 88 was the lowest one which I could see here, but still look at the snoring. There is repeatedly very quite large number of snoring events which I can see here. So what I can do, I will further increase, although there is no apnea and hypopnea, but there is snoring and desaturation. So I will increase the pressure further to 10. Now at pressure of 10, can you see here almost, this is the artifacts, by the way. Your snoring looks like this, okay? Very dark shadows, structures here, waveforms. But here, it is almost normal. Okay, these are the artifacts. And look at the flow graph. It is absolutely normal. Look at the saturation. Saturation is almost perfect. It is more than 90% throughout. It is 94, 93 like this. So now you can see that your CPAP of 10 is your optimal titration, optimal optimal PAP that is required for this patient. Okay, CPAP of 10 is where you are able to see everything has stopped. No, so now this becomes your optimal titration. Okay, so now here again, after some time, what happened? We thought that was adequate. Okay, that was adequate pressure. But then what happened? Again, at pressure of 10 in supine sleep, patient got the REM sleep over here. See, RRR stands for REM sleep. So patient is in supine position and I can see REM stage over here. But look at the C flow. Again, I started seeing hypopnea here. And whenever he had hypopnea, his saturation started slightly dropping down, but it is still around 90 to 91. But here I can see 87, 88. So what I will do next? I will further increase the pressure, okay, to 11. And if I will further titrate it, if my pressure will go beyond 15 centimeters of water, then what I will do? I will think of switching to BiPAP, okay. So for BiPAP titration, what is the guideline? So now here, remember one thing, that your EPAP, we know that EPAP is equivalent to your CPAP or PEEP, right? So now your EPAP is the one which is equivalent to your CPAP. CPAP or EPAP is the one which actually open up which causes the pneumatic splint and it prevents the obstructive apneas from happening. Okay, so this is very important to understand that if you want to reduce your apneas, if you see apneas anywhere, then in the entire polysomnography titration study. So in that case, what you will do, you have to increase your EPAP level. Okay, but if you want to increase your tidal volume or hypopneas or RERAs, okay, if you want to treat those things, then in that condition, you have to increase your IPAP. Okay, so now for BiPAP, you should begin with EPAP of 4 is what is recommended. Okay, and the minimum difference between IPAP and EPAP should be 4 at least. That is minimum. Okay, the difference cannot be less than 4. And we will see like what is the maximum and all those things. We will see it in consecutive slides. But I wanted to tell you this thing so that it will be easy for you to understand like exactly which pressure I am supposed to increase in what condition. Okay, so now if you have started with your EPAP at 4 and IPAP at 8, then wait for 5 minutes. Again, same protocol you have to follow. Wait for 5 minutes and look for the obstructive sleep apneas. Look for the hypopneas. If there is more than 2 obstructive apnea, then what you will do? If it is more than 2 obstructive apneas that you have seen, so what you will increase? Which parameter you are supposed to increase? You are supposed to increase your EPAP. Okay, so now for example, I decided my EPAP was 4, IPAP was 8. So now I saw almost 3 obstructive apnea. So what I will do? I will increase my EPAP because that I am seeing obstructive apnea. So I have to eliminate that obstructive apnea. So in that condition, I have increased from 4 to 6 now. Okay, so my EPAP is 6. So what should be my IPAP now? I will also if you have increased your EPAP by 2, then you have to increase your IPAP again by 2 because the difference between IPAP and EPAP should be minimum 4. That is what is essential. Okay, so if you have decided to increase your EPAP by 1 centimeters of water, then your IPAP also should be increased by 1 centimeters of water. Okay, so now if you see any of these events, same thing, 2, 3, 5, 3, then increase your EPAP first and then increase your IPAP consecutively. Okay, again, wait for 5 minutes and try to look for these apneas and hypopneas. Okay, so now, for example, now your pressure is 6 and 10, for example. Okay, so at pressure of 6 and 10, now you were not able to see any obstructive apneas, but you can see hypopnea. So what you will do in this case? You will just increase your IPAP. Don't touch EPAP. EPAP you are supposed to touch only when there is obstructive apnea. I hope this is clear. Okay, so now maximum IPAP that you're supposed to go is till 30 centimeters of water. Okay, this is the recommended maximum pressure that you can go. And rest exploration and everything is similar. Only this is important, that which parameter you will increase when you will see obstructive apnea and when you will see hypopnea or RERA, all those things. Okay. So this is what I told you. So whenever you are doing a transition from, and now it is important. Now at what pressure, like for example, I told you when your pressure will reach till 15 centimeters of water on CPAP, then you are supposed to switch to BiPAP. But then at what pressure, now I will start. Like if my CPAP was 15, then should I switch to BiPAP and keep my EPAP as 15? And then again, if my EPAP is 15, then IPAP should be 19. Okay, is it the right pressure that I'm setting? No. Okay, so what is the criteria for that? Whenever you are doing a transition from CPAP to BiPAP, the minimum starting EPAP should be set at 4 centimeters of water, or CPAP at which you saw the obstructive apneas were eliminated completely. Okay, so if you see that on your CPAP, if your for example, if your apneas were getting eliminated at 6 centimeters of water, then you have to start your EPAP. Okay, in BiPAP, you have to start your EPAP. You have to keep your EPAP as 6 and then plus 4. Plus 4, 10. Okay, so 10 should be your IPAP. So the pressure becomes on BiPAP, your starting pressure should be 6 over 10. Okay, that's how it is decided. Okay. So similarly for pediatric patient, it is same. Only thing is this 1131. So I'm not going to repeat it. We are running out of time also. Okay. So now for the same thing, if for pediatric patient, for pediatric patient, your minimum IPAP should be 8 and EPAP should be 4. Maximum IPAP that you can keep is 20. And IS2 difference is always, doesn't matter in adult or pediatric, it is minimum difference between IPAP and EPAP is always 4 centimeters of water. And maximum difference that you can keep is 10. Okay, in pediatric patient. For adult patient also, everything is same except the highest pressure. So maximum pressure in pediatric is 20. In adult, it is 30 centimeters of water. Okay. But you can always start from 4 to 8. Okay. Now, I have already explained you these things, but this is just a revision. I hope it will be clear for you. So increase both. Okay. So increase both. This full screen I cannot see over here. I don't know how to. Okay. So increase both IPAP and EPAP by 1 centimeters of water. Okay. In an interval no less than 5 minutes when you see. So you have to increase your I don't know whether you are able to see this full screen, Rujuta?
Yes,
Yes, Sulochana, we are able.
Okay. Yeah. So if your patient has 1 hypopnea, 3 RERAs, or 1 minute of loud ambiguous snoring in less than 12 years of age patient, then you are supposed to increase your IPAP and EPAP both. Okay. So, sorry. I guess there is some mistake in my slide. Okay. So the thing is, actually this got repeated. You're supposed to increase your IPAP and EPAP only when your patient has apneas. Okay, so I apologize for this mistake. This is a different, so kindly ignore this part. Actually, you're supposed to increase your IPAP and EPAP both when you have apneas. Okay, so when you see 1 apnea in a pediatric patient, then you will increase both EPAP. The moment you see apnea, you have to increase your EPAP. If you are increasing your EPAP, then you are supposed to increase your IPAP. This is the gist. Okay, so this is the thumb rule. So which is you are supposed to know. Okay, in adult patient, 3 apneas. You have to see whether sorry, two apneas. So you will see, look for two apneas. If you see that there is two apneas which is seen in an epoch, then you will increase your EPAP. If you're increasing your EPAP, you have to increase your IPAP also. Okay, but you have to only increase your IPAP when you see hypopnea rara or snoring in adult or pediatric patients. Okay. So same thing, it is an optimal, I'm not just going to repeat it, it is the repetition. Okay, so you can again in BiPAP also, there is something called as optimal titration, good titration, adequate titration, and unacceptable titration, which is similar to your CPAP titration. Okay, so now let us see the graph actually. Again, let us come back to the graph, polysomnography graph here. But this is, initially your patient was on CPAP, but you saw that at 10 pressure, 10 CPAP also, your patient was still having, he had return of his hypopneas, okay? And you further increased your, you kept on increasing your pressure was already 15. So you thought of switching back to BiPAP, switching to BiPAP now. Now here on BiPAP, what you did, this is a 2 minute of window period, okay? Okay, so I cannot see what exactly is seen here. This is my screen. Okay.
See the screen. We can see your
Okay,
screen.
yeah, now it is fine, I guess. Yeah. So now what you did is, as per the recommended guidelines, you started your BiPAP with what? EPAP of 4 and IPAP of 8 now. Okay. So now here, look at this graph. Again, let's see. There is no snoring here at all. But if you look at the CPAP flow or your BiPAP flow, you can see there is cessation of breath here. Can you see the waveforms has paused entirely? Okay, there is cessation of breath over here. So in this case, what you did, now you will think again, you know that this is apnea. So what you will do, this is apnea, this is complete flat, right? This waveform, this is completely flat. There is no waveform here. So in this indicates that your patient has apnea. This is two apneas in one epoch. So then you will consider of increasing the EPAP. So if your initial EPAP was 4, okay. So now what you will do? You will try to increase it by 5. Okay, huh. So you have thought of increasing it to 5. You will increase your EPAP to 5. So if you're increasing your EPAP to 5, then your IPAP is also supposed to increase by 1 centimeters of water, which is 9 now. Okay. So in next epoch, again, what you saw now, your BiPAP pressure is almost around 9 by 5. Okay. So at this also, what you can see, you can still see there is apnea here. So again, further, you thought of increasing the pressures. Oh, why it's not moving? Can anybody help me? I don't know. Got stuck or something. Okay.
Probably your internet is a little slow, so it is taking time. There might be a
Okay.
lag.
Okay. I can't move it further.
You can probably exit and try it.
Yeah. Can you see this one? Like, I
Yeah.
hope this.
Yeah.
This is visible,
Yeah.
right? Okay. So here I'll explain here only, like I'm about to finish. So this is here now again we could see there are apneas here. So now you have increased your pressure to 6/10. Okay. The moment you see apnea, you have to increase both the parameters. Then next, after this, okay. So now here at pressure of 6/10, EPAP of 6 and IPAP of 10, you could see that now your C flow, the flow here, the waveforms are present, but it is reduced in height. It means the flow is gradually reduced. So it means this is hypopnea here. So in hypopnea, what you will do? You will just increase your IPAP. So now you will increase your IPAP from 10 to 11 now. Okay. But your EPAP remains the same, 6. Now again, in the other graph, next graph you saw, in next epoch you saw, still you can see here hypopneas over here. So what you will do, you will further increase your IPAP to 12, but EPAP will remain the same.
Timer.
Okay. Hello? Yeah. Okay. So now once you have reached pressure of 12/6, Now what you can see, there is no respiratory event here and there is no snoring also. So this indicates that you have reached your optimal titration. Okay, so in this case, what you will do, you will just observe and monitor this patient. Okay, so this is how we do the titration, and you can give supplemental oxygen to those patients whose saturation is less than 88%, but there is no respiratory event at all. So in their condition, you are supposed to give them supplemental oxygen. Okay, but yes, exceptional is always your COPD patient, because in COPD patient 88 to 92 is what is considered to be normal. Okay, so if your pressure goes beyond that, if your saturation goes beyond 88%, then you can give them, think of giving them oxygen therapy. Okay, so I'm not going to read it out. I guess, yeah, so the summary. So first, to wrap it up, for CPAP titration, the recommended maximum CPAP for patient less than 12 years old age, 15 centimeters of water, and for adult patient, that is 20 centimeters of water. Okay, the RDI should be less than 5 event per hour. Okay, and the saturation throughout titration should be more than 90%. For BiPAP titration, optimal EPAP is achieved when the apneas have been eliminated. Okay, when optimal IPAP is achieved when all the arousals or desaturation has been eliminated. Okay, the minimum difference between IPAP and EPAP should be 4, but maximum that you can keep is 10 centimeters of water. Okay, so with this, I would like to conclude my session. Thank you for your patient listening, and I am really sorry for extending my time. So if you have any questions, I'd be happy to take it.
Thank you so much, ma'am. Thank you.
Thank you.
Uh,
Thank you, ma'am. Thank you so much.
Questions at end, not an issue.
So considering the best interest of the time, I think we could take up the sessions in the chat box and ma'am could answer them in the chat box. We are
Sure.
already 30 minutes delayed, but I
Yeah.
think the sessions has been surely informative, and I think we have a lot of things to take back on. So quickly, without wasting any further time, we would move on to the next session, which is on simplifying CPAP education. For that, we have with us Mr. Selva Kumar. Sir has a PG diploma in respiratory therapy in Preston CMC Vellore. Sir is currently working as a sleep technologist in the department, and he is being involved in sleep studies and performing CPAP titrations. So I welcome you, sir, and over to you.
Thank you, Rujita, for introduction. Very good afternoon for everyone. I think this is almost sleep time and lunch time. I think all of them ate or we are eating in the front of the session. Thank you for a wonderful opportunity given to me in the IARC and Maharashtra Regional Committee and Sulochana. Thank you, Sulochana, for the opportunity. Okay, my topic is simply. I'm audible. My screen is visible.
Yes. Yes.
Okay, thank you. Thank you. So my topic is simplifying CPAP education, almost covered by the Sulochana. I'll do some, if anything is continuing, I'll skip that slide. Okay. Okay. The introduction continues. What is CPAP? The CPAP stands for the end of session. Students will get some surprise. Okay, please be patient or listen something. Okay, that stands for continuous positive airway pressure. It's the treatment, the main thing for OSA, obstructive sleep apnea. The CPAP will keeps your airway open and gently providing through mask and wear while you sleep. The next main application for CPAP maintenance, it will be PEEP, the positive end expiratory pressure. It decrease the atelectasis, any collapse or is there or not. Increase the surface area of the alveolus, improves the ventilation perfusion mismatch. Okay, and then improves the oxygenation. So this is all I know the anatomy and physiology. The anatomy start with nose and pharynx, larynx, and the trachea, bronchi. This is the respiratory system in our body. That will finally will be in the alveoli. Some portions of the respiratory tract, the upper airway obstruction may due to the excessive tissue, tonsillar overgrowth, or some obesity, the neck circumference increase. That's the main causes for upper airway obstruction. So the CPAPs deliver the pressure, hit airway pattern, and to prevent the collapse of the airway. Okay, this is the CPAP. This is a very simple principle. It's look like this. This is a CPAP device, just like a blower and air filter, humidifier. That is optional. CPAP tube and mask. This is the mask. So as you all know, the indications are mainly for the OSA. That's called the obstructive sleep apnea. This may be in the causes of obesity, hypertonia, and tonsillar hypertrophy, among others. CPAP to treat the. Is there any disturb something?
You can continue,
Should
sir.
I keep-
Yeah,
Okay, thanks. Okay, this true. It is CPAP to treat hypoxia and decrease the work of breathing, the main thing, and the oxygenation, improvement of oxygenation, PEEP, and artificial airway during endotracheal intubation. The obese patients with obstructive sleep apnea, patients with congestive heart failure. So contraindication, so many relative contraindication is the very uncooperative patients, reduced consciousness, unable to unstable cardiorespiratory status, and trauma and facial esophagus, like that. So many contraindications, and just you go through this one. Then severe air trapping disease with the hypercarbia, asthma, COPD, like chronic obstructive pulmonary disease. Okay, that's equipment is the device called the CPAP, that stands for continuous positive airway pressure. The nasal CPAP we can use, the nasopharyngeal, via nasal pharyngeal we can use. Then CPAP machine includes the straps and mask, hose, everything. Then one more thing, the bubble CPAP, that's old, that pediatric patient, neonatal, they can use that bubble CPAP. So that's a complication, the different complication is there. But what I prefer, I very personally related to the two complications. One is there is a nasal soap. This is a very important for in our all the phase. So we should careful for this while preferring the CPAP. Then abnormal distension. If any while taking the breath into the mouth, it will go into directly into the esophagus. That also very common complication that we should prevent. The next one, nasal CPAP therapy, it's was described in 1981. You can see this, the picture. The first picture shows the obstructive somewhere in the outside collapse the airway. So you can see that centimeter of already Sulochana told that CPAP titration. The first thing, it's a very narrow. There's so much obstruction is there. While giving the 15 centimeter H2O, this airway will be open. That is the main thing for the nasal CPAP therapy. So this is not only only 1 month thing. You have to the teamwork, the respiratory doctors and respiratory therapists and sleep technologists and the nurses, the other healthcare professions involving this program. So this is the enhancing healthcare team outcomes. So CPAP is often described by the respiratory doctors and RTs and patients with who are in the obstructive sleep apnea. Then one more thing, the compliance is a very good thing. Then patient education is is vital. Many patients use this device for the short time because of discomfort. Then we have to educate the patient for how to use, what is the problem. Then and all you have to educate the patient. That's the main thing. The other, you have to encourage body weight, lose of body weight, eat healthy, and discontinue the smoking. That's the main thing. So next thing is the clinical significance. The mode of the PEEP, the positive end expiratory pressure, delivers the hospital setting and home environment also. It can improve the pulmonary hypertension and blood pressure and can be used for safe all ages, including children. So the inpatient setting is a little different. The outpatient in the home-based CPAP, that is a little different scenario. So complaints. Let's talk about the complaints. It's a very important for all. Once we prescribe the CPAP, So we cannot leave the patients. You have to call the patients for 3 to 6 months. We have to see the patient's data, how it is machine is working or not. Patients are patients are okay. The symptoms worsen or decreased. You have to, everything you have to ask the patient. That's the main thing for the complaint. That's main focused on the complaints. Okay, shall we see some in the complaints report analyze? So main thing what you have to see, the AH is called as the apnea hypopnea index. So leak on the interfaces, patients how many days used or not. So that everything given by the machine. The machine we have some card read memory card will be there. That will show the how much times the patient used, then how much leak is there, how many days, how many hours, then everything show this in this report. So the first report is the 180 days. And the AHA will be less than 1.2. The normal range AHA will be in the less than 5. The patients are well okay. Then 28 leak also very this normal range only. Then you have to see that the interfaces that under the patient is over nasal mask or face mask that under. If anything, patient wants to correct, you have to give some comment like that. If any leak is there, that we have to see. The second report you have to see the leak will be 45% is more than not in the limit. So we have to instruct the patient how to use that. Then you have to any leaks beyond that 45 like that, you have to check that device, tell to company people to see the service like that. Then any problem in that tube, the hose, like that long tube will be that you have to, any leak is there, I have to check. So this is the complaints report analysis. So this is a comparison of that online titration before the CPAP and the after CPAP. The first maybe in the dog line and the maybe apnea, the desaturation that and apnea, hypopnea, obstructive that shows the first half. The second one there is nothing. The saturation also improved. That's this pictures reflect that one only. Okay, that's obstructive sleep apnea. So I think everybody is clear about the obstructive. What is it? It's normal airway. The first picture show the normal airway. The second picture, somewhere in the fall in the tongue pushed back, it's a collapse that airway. That's the main thing for obstructive sleep apnea. So risk factors, the main cause for male and obesity, older age, and certain anatomical features, large tongue or tonsils. Okay, symptoms, everybody knows very clearly, snoring. The main thing is snoring, gasping, choking, and excessive daytime sleepiness. So as you all know, the Malampati classification of man, this is the main thing. There are 4 gradings will be the first thing is a normal, the second is partially, not partially, that's mild and moderate, severe. The fourth will be the complete airway collapse. This maybe in pre-anesthetic clearing, they will use to any patient they wants to do a surgery. Before they will send the that PAC pre-anesthetic cleaning, they will assess the Malampati airway. Then only after then during the procedure, the intubation will be easy. They will decide how to intubate like that. So what is PAP? PAP is nothing but positive airway pressure. Is delivered the positive airway pressure through nose, mouth, or both. So like the blowing, like some pressure kind of thing, then the upper airways will be open to the lung in the undisturbed. Okay, sorry. So the types will be one is the continuous positive airway pressure, one is the auto CPAP, that is called auto adjusting positive airway pressure, and the bilevel positive airway pressure. So why I should wear at the night? So patient definitely will ask why I have to use this machine. Then that cost also a little high comparatively, but you have to tell the patient the snoring is not will be there. They improve the sleep quality and symptoms, improves the control of other chronic disease. So goals of PAP titration, it's a main thing is airway will be open, stabilize the breathing patterns, and user set parameters are needed for optimal therapy, efficacy, and adherence. So treatment is a main treatment, positive airway pressure and continued positive airway pressure. First line treatment is for moderate to severe OSA. It's an opinion, there's an option for mild OSA. That's studies done have shown in the inconsistent results. So auto CPAP. This auto CPAP is nothing else. It is automatically give the pressure. So adjusting the how much pressure is the patient needs during the sleep. So the treatment OSA per patient without cardiovascular and pulmonary comorbidities. So auto CPAP device can be used to determine the optimal pressure. I think Sulochana mentioned in the optimal pressure, and that and all it will include this thing, OSA patients without any comorbidities. So this is auto CPAP report analysis. So what you have to see in the main thing, the patient's height and weight. Ma'am, Soumi ma'am mentioned in the assessment. So that is the patient neck circumference, ESS, Mallampati, stop band, then AHA may be in the, you can see the polysomnography study or limited sleep study. That we can see that AHA and desaturation index. So after the study, so we have to see the pressure and the 95th percentage and the maximum pressure. So this is the patient that good CPAP report. Then AHA also will be reduced. The AHA is less than, after CPAP use, the AHA will be 2.2. That in polysomnography studies, the AHA will be 43, almost eliminated AHA. That's a good thing for the. Then you have to see the graph also. Once you can see it, you cannot see only in the number. You have to see in the pressure graph and AHA and leak. Sometimes we can correlate the maybe age is not eliminated, showing the machine showing some the for 7. Sometimes they can see the graphs, maybe age and partially completed. Somewhere in the midnight, our patient wake up, that they can show in the report. So we have to see the all into the this graph everything. Then values also. So this is the second Asian report. The age will be more than 75. So in this the median pressure and if there's the maximum pressure. In the maximum pressure, we can't give the we cannot prescribe for the auto CPAP. You have to go with the BiPAP titration. Then is there any other comorbidities like any overlap syndrome, OSA, OHS, COPD, asthma, like that? So I have to see that. That and all you have to clean while see this report. So this is the main thing for the CPAP. The CPAP will be open the airway. So this is our airway and bronchoscopy pictures. The first pictures will fully collapsed. The second picture will be in the some positive airway pressure we are giving. It will be a little open. So next will be in the right side. The third picture will be in the left side will be fully blocked, maybe in the stenosis or some external compression like that. So there's this picture, so this like a bronchial stent or tracheal stent to prevent the airway collapse. So this is during bronchoscopy real time. It's airways really is opening or not. There's a pre-procedure image. There's after procedure. I'll show this video. I think yeah, you can see this. I couldn't get the proper video. The right side. This is the normal. So 3 lobe we cannot see in this picture. So once after the last thing, we'll give some pressure. This patient needs for 10 centimeter of H2O. So the last some fraction of second you see some the airway will be open. So this is this pictures indicating. Okay. There's next thing, the bilevel positive airways is nothing about. We're giving the CPAP will be on a constant pressure, and the CPAP automatically adjusting the pressure. The CPAP, sorry, bilevel will be in the 2 level. Is the one is inspiratory and expiratory. They're associated with some any obesity, hyperventilation syndrome, then lung, any other drastic lung disease, and the kyphoscoliosis, any scoliosis like that. This is, I think. This is the program. I have to see the what study we are going to do the patients. So severity of this is the pathophysiology OSA. So explanation how we are going to do the procedure or like the disease condition. So counseling treatment, the outline patient role in treatment, then address their concerns and set goals, then patient quality assessment, and then feedback for regarding evaluation. This is the type of mask, the nasal mask. So nasal pillow mask and the nasal device mask. This is already covered Sulochana, full face mask. I'll tell you how to one thing I want to show you, interface selection and the mask fitting. So some company, they're giving some scale and you have to see this. For the first video, I'll show you. This is the That is a nasal mask. This is a full face mask. We have to select the Indian. So like, wow, we are choosing the dress. If I'm using the M size, the M is the medium. So if I cannot wear the large size, I mean, I'm not like good. So like that scenario, I have to apply for the all the patients in the need. I'm so really sorry. Okay. Okay, that's improving the patient comfort and tolerance during the titrations. The leak is very important. Then process of the mask leak and the fitting the headgear, improper mask size. Those strategies attempt to reduce the leak for the by resetting the mask, ensure the mask is not over tightened. Then that also causes the nasal sores and mouth dryness. Try a different types of mask, the interfaces. Introduce the chin strap or full face mask in the mouth is leak unresolved. The humidification very important for in this topic. So we are giving the some pressure. Maybe patient cannot tolerate that pressure. Maybe dry mouth, the headaches, bad breath, sneezing, swelling, infections. That the general discomfort. So to address the dryness, the humidifier considers small attached to tank, like the distilled water which releases moisture. Then you should tell the patient you cannot use the daily basis. If you have any, maybe in the summertime they can use, then not winter time. That also creates some infection. They are using that not proper washing. They're not proper means water also contaminated water. That also creates some infection. That and you have to teach the patient. So cleaning the CPAP unit and the accessories. So daily is wipe the mask and nasal pillows and replace the water one in your humidifier. If you are using once, then weekly once tubing and the mild soap water, no, not mild and soap water only you can use the and liquid soap only advice. So filters you have to use the they weekly once you have to just take a then flash it and use it for wash with do not wash with water. So wipe the device, cloth or tissues, and like then you have to tell the patient this is electrical. It's coming using property. So you have to unplug your CPAP and before wiping the avoid to the electric shock. Replacement of the supplies and the parts. So recommended anything you want to change the replacement schedule by you have to change the machine. So every 3 to 6 months, why that some filter will be in the behind the machine. So you have to change the machine every 3 to 6 months. Then yearly will be tubing will be changed because maybe the damage also will be there. We don't know. So you have to change the thing. So main thing, then you have to educate the patient the sleep hygiene. So restrict the caffeine product, restrict the other drinks, but then with activities, Coke, tea, chocolate like that, no alcohol. That's a fully prohibited. Restriction of smoking, that is a very important thing, the restriction of smoking. So regular physical activity, like walking, that's small exercise, like the reduction in the noises in the bedroom. To instruct the patients, bed will be comfortable. It will be that is a very important for any noisy. The electronic devices are not used. The bedroom will be very pleasant and the proper ventilations in the bedroom. Okay, that lifestyle modification, behavior, weight loss, upper airway exercise. This is the main important. We have to teach the upper airway oropharyngeal exercise to increase the muscle tone. So thank you for listening my presentation. So this is questions were only for students. Simple in words, put it in the chat box. What is the expand of CPAP? So write in 2 indication and contraindication. So how many grades are in the myelopathy? Types of interfaces, types of PAP. Okay, thank you for listening.
Thank you so much, sir. So I think we are towards the end of our session for today. I understand it's been a very long session. We have really short our time limit by almost an hour. But I think this has surely given all of us and all the delegates out here a quite clear understanding about polysomnography and the basics of polysomnography. So I see many of us have asked and requested for the videos for this session. I would request everybody to go and subscribe to the YouTube channel of IARC, and I think this session has been live streamed there, and you can view the video there. We now move on to the conclusion of our webinar. I would like to invite our Miss Madhura Gauri Shevde, our very own chair of the Maharashtra Regional Committee. Ma'am is the manager training programs at the Chest Research and Training Institute, Pune. She is also the vice chair of the Indian Academy of Respiratory Care and the editor-in-chief of the Indian Journal of Respiratory Care. So I welcome you, ma'am, and request you to kindly conclude the webinar session. Thank you so much.
Thank you, Rujita. Thank you to the audience for staying till the end. We were extremely happy that we had such huge numbers register for our training program, and more than that, such huge numbers continue to remain with us even after we spent 1 extra hour trying to cover up our sessions. So thank you very much for that. So let me begin with thanking Ms. Sulochana, who was the brainchild behind this webinar. She, along with Rujuta, who has been supporting her, has kind of put up this program. So congratulations, Sulochana, and well done for whatever you've worked hard in the last couple of weeks for. On behalf of the Maharashtra chapter for IARC, I would like to extend my heartfelt gratitude to the Central IARC committee, especially Dr. Soumi ma'am and everybody in the EC who have supported this program that we've had today, especially with the last minute upgradation of the Zoom platform, which we were really scared of. We didn't know what we were going to do, but the Central Committee really supported us in this. So thank you from all of us to you. Thank you to all of the speakers for spending your half or more than half of your Sunday, guiding our participants in the various aspects of polysomnography. This is just the beginning, and we hope to have such more programs, more detailed programs on various such novel topics that can definitely help not only our students but our practicing RTs, and we extend it to our other healthcare providers as well. So we are glad that we can share this platform with everyone, and we hope that we can see you again soon. Anything related to the program, the certificates, anything that remains, I think you will get an email about that. But safe to say that if you've attended at least half of the program and participated, probably you will get a certificate, provided we are able to identify your name and cross-check that with your registrations. So that I leave it all to our organizing team. And again, thank you for joining us today, and we will see you in the next program. And thank you.